Good morning, everyone. I, Dr. Supriya, feel privileged to welcome you all to today's program, organized by our Tobacco Cessation Center in association with the Indian Academy of Oral Medicine and Radiology, and in collaboration with the Department of Oral Medicine and Radiology, Department of Public Health Dentistry, and the Department of Psychiatry. Now I kindly request Dr. Rachana Prabhu and Dr. Anubabu to escort the dignitaries onto the stage. This initiative reflects our collective commitment to strengthening tobacco awareness, patient counseling, and preventive oral health care in alignment with national standards and our shared vision of holistic patient care. To begin our program, I would like to invite Dr. Syed Migdad, Reader, Department of Oral Pathology, on stage for the invocation.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يا أيها الذين آمنوا إنما الخمر والميسر والأنساب والأزلام رجزا من عمل الشيطان فاجتنبوه لعلكم تفلحون. Oh, you who believe, intoxicants, gamblings, idols are impure from the work of Shaitan, so avoid them that you may be unsuccessful. Thank you.
Thank you, sir. I now invite Dr. Rachana Prabhu, Professor, Department of Oral Medicine and Radiology, to deliver the welcome address.
Respected dignitaries, faculty members, delegates, and my dear friends, a very good morning to everyone present here. It gives me immense pleasure on behalf of the entire Tobacco Cessation Center team to warmly welcome you all to this national CDE program organized by Tobacco Cessation Center in association with Indian Academy of Oral Medicine and Radiology. On this forum, I would like to briefly share a few words about our TCC. Although I am the in charge of TCC, it functions as a true team effort, involving an oral physician, a community health dentist, a counselor, and a social worker. Together we work for the benefit of our patients and the community by creating awareness and supporting individuals in quitting tobacco. As dentists, we are often the first point of contact in detecting tobacco-related oral lesions and preventing oral cancer. With this thought in mind, we initially planned this program as a small initiative. But then, under the guidance of our Honorable Pro-Chancellor Sir, Dr. M. Vijay Kumar Sir, and the support of the National President of IOMR, Dr. Prashant Shenoi Sir, it evolved into a national level program. I'm very happy to share this first of its kind national program. It has received an overwhelming response with participation from over 68 dental colleges across India and more than 600 registrations, including almost 172 offline delegates, even at a very short notice. It's indeed a great honor and privilege for us that our Honorable Pro-Chancellor Sir, Director and CEO of Zuleika Institute of Oncology, Dr. M. Vijay Kumar Sir, has graciously accepted our invitation to be the chief guest and resource person for today's scientific program. We extend a warm and respectful welcome to you, sir, and eagerly look forward to your valuable insight. It's also my privilege to welcome our guest of honor, Dr. Prashant Shenoi, sir, Professor and the current National President of the Indian Academy of Oral Medicine and Radiology. Taking this program to a national level would not have been possible without his support and guidance. Thank you, sir, and we welcome you for this program. I would also like to extend a warm and heartfelt welcome to our beloved principal, Dr. Lakshmikant Chatra, sir. Sir has stood by us from day one, and the Tobacco Cessation Center was initiated under his leadership. We are truly grateful to you, sir, and we welcome you, sir. I also take this opportunity to welcome Dr. Sham S. Bhatt, sir, Dean, Faculty of Dentistry, Dr. Akhtar Hussain, sir, former Dean and Secretary of Islamic Academic Education, Dr. Hassan Sarfaraz, sir, Vice Principal, for their constant support and encouragement towards this program. It's my great pleasure to welcome our second resource person, Dr. Anil Kakunje, Professor of Psychiatry and member of our TCC team. We are truly grateful that he has accepted our request to be a part of this program today. We welcome you, sir. I take this opportunity to welcome Dr. Maji Jose ma'am, Dean, Student Affairs and former Deputy Director for Center for Substance Abuse Prevention. Then all the HODs of our neighboring colleges, Dr. Raghavin Kini, sir, HOD of AJ Dental College, Dr. Jai Prasad, sir, HOD of KVG Sulya, and all the heads of the department from our college and the constituent colleges. I extend a heartfelt welcome to all the faculty members of neighboring colleges, our college, and the constituent colleges of Yenepoya University. I would like to welcome and acknowledge Dr. Abhinash Tejaswi, our esteemed alumnus and honorary secretary of IOMR, who could not be with us in person today due to prior commitments, but he has joined us online. I welcome all the IOMR office bearers for joining us. They have joined online, and we sincerely thank each one of you for your support. A special welcome to all our alumni who have traveled from far and wide, and also many of them have joined online, and they have extended their valuable support for this program. Whenever meaningful work is accomplished, it is always the result of collective effort, and today it's no exception. I take this opportunity to welcome, warmly acknowledge and sincerely thank the heads of the department of 3 collaborative departments, that is Dr. Rekha Shenoi, Head of the Department of Public Health Dentistry, Dr. Veena KM, Head of the Department of Oral Medicine and Radiology, and Dr. Ravi Chandra Karkala, Head of the Department of Psychiatry, for all their unwavering support and contributions towards the success of this program. Last but most importantly, the success of any academic program is determined by its participants. I extend a warm welcome to each and every participant who has joined us and contributed to making this program a grand success. Thank you for being a part of this important initiative, and I wish this national CDE program a great success. Thank you. And we have received a message from some eminent personalities. One among them is Dr. Shailesh Lele. Shailesh Lele sir is a former IOMR president, and we thank Shailesh Lele sir for his kind message and extending his best wishes for the success of this program. Thank you.
Thank you, ma'am, for that warm and heartfelt welcome address. I now invite our esteemed dignitaries to kindly come forward and light the lamp to mark the beginning of this function. Now I call upon Dr. Tashika Kushraj, Reader, Department of Oral Medicine and Radiology, to introduce our guest of honor for today.
Respected dignitaries, my dear colleagues, students, a very good morning to all of you. Professor Dr. Prashant Shenoi needs no introduction, especially after hosting 2 successful national conferences. Sir has been actively involved in oral medicine and radiology for more than 3 decades, teaching, learning, organizing, and innovating. His zeal to improve the specialty is commendable. Sir is a certified implantologist and has received advanced training in CBCT from Helsinki, Finland. Sir is also an excellent clinician with more than 30 years of private specialty practice. Professor Shenoi has more than 230 scientific publications and has delivered more than 50 guest lectures at professional and academic forums. Sir currently serves as the President of the Indian Academy of Oral Medicine and Radiology, having previously contributed as Vice President and Honorary General Secretary. His leadership has been transformative, introducing digitalization, electronic voting, and website upgradation within the Academy. Sir has also served as past President and Secretary of the IDA Dakshina Kannada branch. He's also been the past President of the Mangalore Junior Chamber. Professor Dr. Prashant Shenoi was awarded the Best President Award at the national level Junior Chamber India from among 500 local organization presidents. IDA Dakshina Kannada branch was awarded the best branch at the state level during his tenure as a president. As the head of department, the Department of Oral Medicine and Radiology was recognized as the best department twice. At the national level, he has contributed to the Government of India and World Health Organization in supporting their manuals on tobacco cessation, oral cancer, potentially malignant disorders, and rationale for antibiotic use. He also serves on the National Oral Cancer Registry Committee representing South India. All these awards and contributions, ladies and gentlemen, proves Professor Shenoi's outstanding leadership qualities and administrative acumen. Beyond his impressive credentials, what truly sets Dr. Shenoi apart is his personality. Though he may appear firm and disciplined on the outside, he is deeply sensitive, sensible, and compassionate within. His patient-centric approach, practical problem-solving skills, out-of-the-box thinking make him a clinician par excellence. As a mentor, he has guided generations of students like a true leader, working hand in hand with our respected principal, Dr. Lakshmikant Chatra, in building the department to the standards it enjoys today. His sharp wit and spontaneous witty responses light up every academic discussion. He is not only the life-driving spirit of the department, he is also the pillar of strength who always stands firmly by his staff and students, supporting them in every challenge and celebrating them in every success. Ladies and gentlemen, please join me in warmly welcoming a distinguished leader, an inspiring teacher, a man of integrity and conviction, Dr. Prashant Shenoi. Over to you, sir.
Thank you, Rashika. This commas and full stops makes a difference. So when Tashika started saying, though he appears disciplined, and she gave a comma, I said, now it is coming. He is not one. Anyhow, so comma and it makes a difference. Anyhow, Honorable Chancellor, Dr. Vijay Kumar sir. Sorry, what is your pro-chancellor? This this is again the confusion between Vice Chancellor and Pro Chancellor. So there is always a confusion. So I prepared my whole this thing because most of my activity with him was a Vice Chancellor. So this is the second person I think I am promoting him. Just other day also somebody promoted you, sir, in oral pathology testing. So now principal, I will address him as principal only, principal of Chhatra, Dr. Akhdar sir, the Dean, Shambhat sir, Dr. Anil Kakunji, Dr. Sarfraz, Dr. Achana, all the dignitaries who have come here. Now it's truly an honor to stand here. So now most of the time I wasn't there, or even if I was here, I was in the corners, but it is very difficult to be in the center stage. So I'm getting used to it. So now since so many people have joined online from all over India, so it is the president of the IOMR who will be speaking, not the Prashant Shenoi of this college. Okay, so but basically I am that, but since a lot of people are there. Sir, the IOMR is an organization which of around 3,000 capacity now. So once I was elected as the president, I realized something important, that it is not just the post, it's a responsibility which is entrusted on me. This particular post is very temporary. It's like a rented house. You come, you stay, you serve, then you go. So what you require is a group leadership. So as a leader, I should be convincing people. Sometimes I confuse people also and get my work done. Okay. So during this short tenure, so our aim was simple. So as a joint secretary and the joint secretary, we learned something for the academy. See, now when I'm in the academy, I should be working for the members first. So the members, because they have elected or selected us. So one of our first tasks, as I was a secretary, what we did was, in some of the universities, this oral medicine specialty was grouped under non-clinical branch. Many of these things. That is basically on admission purpose, because the fees were quite, sometimes it was low, so they just said clinical subject, non-clinical subject. So all over, so we had to really had a legal pattern from the academy. So most of these people, they have rectified, and definitely there is no need for anybody to say oral medicine is a clinical subject. But as an academy, as a group of people, we had to do that maybe 2 years back. Then it came of the staffing pattern. I think this staffing pattern issues are there in PIDO also. As an academy, I think we realized the DCI said for every 100 students you require 1 read. But as far as the post-graduation went, we require 10 or 10 staff. So we could successfully represent people, the government, health ministry, as well as the dental council. Now, luckily, the staffing pattern will change. Now the new NDC rule, when it comes, I think this pattern is addressed, because it was there in oral pathology, not in oral pathology, in PIDO also. For 100 BDS students, they said 1 reader is enough to do your teaching. So as an academy, as to specialty, we had to take up this, and we took it up successfully. That was our second. Then the third is, now what is the major challenge what we are facing is non-radiologist people are signing the radiology report, particularly the CBCT report. This is basically happening in many of the metro cities. We have a group of all these radiology centers. So they have made a huge investment. So apart from treating patients, they started doing some 3-hour course, 4-year course. Just yesterday also, I just received one something on Instagram. Want to learn CBCT in 3 hours. Okay. So now what happens is these people are going and signing the radiology report. These couple of things that had happened earlier. So we took up this matter with the DCI. Luckily the DCI was there. At least in the academy, 2 notices and 2 legal battles we had for this. Okay? Because in the radiology side, in general radiology side, they are very strong about this. Okay? So we had to take this up. Reporting, what you call it, interpreting is different, reporting is different. But signing a radiology report, it is something like non-pathologist writing a pathology, signing a pathology report. I may be able to read it, but the signing becomes an issue there. So this was done with the help of this thing, because I think even ortho is facing it. Lot of these people coming in the aligner, the society there in the ortho society are together, they are together fighting this. All literally non-dentists doing ortho treatment. Forget about the certified dentists. So this in the academy we have taken it up. Now, the third initiative what I have taken is we have taken collectively in EC is inclusion of AI into our teaching curriculum. Now this is we are having a national seminar most probably within the next 3 months, because the AI is coming in a big way. Definitely we cannot run away with that. We cannot run away with that. But what I personally or we involved is we were AI into teaching and AI into learning. These two are entirely different aspects. The teaching, so we wanted to put this AI in the learning aspect. Said and done, I always tell two things. Intelligence is artificial, but stupidity is natural. Okay? So it comes naturally. And you should have your natural intelligence to use artificial intelligence. So, but we can't run away with this. So in the academy level, in our curriculum of oral medicine, we are trying to introduce how to use AI in learning oral medicine and radiology. Next, as a president, along with the EC, we felt that we should do something more than conferences, academics, and teaching. Something meaningful to the society. This is where the program like this inspires us. Sir, I sincerely appreciate the organizing team of this TCC also, not only the team of TCC, as well as who are the group of what is called a COAP, the brainchild of our Pro-Chancellor, sir. The Pro-Chancellor, sir, when initially came, so he initiated this cancer awareness program. He called for a meeting, still I remember, around 40-50 people were there initially. By the time 5th meeting came, number started reducing. Only it was a big filter, I felt. It is really a filter wherein slowly interested people only stayed. That becomes the core group. So I also was there in the group maybe sir 60% of the time. Last 40 seconds I also went away. But initial 60% I was there. Then people like Rachana and so many people, they stayed strong there. I actually was going through, from my house also I used to see a lot of people, not lot of people, one person, okay, getting up early morning and going, okay, coming late, okay, into this awareness program. Then one day I was called for one program of this awareness program. Can you imagine at 4:30 in the morning, you go to that MCC laborers who are working there and you try to create an awareness program where 100% people have got pan in their mouth. And they are telling who and they're talking and Rashana is trying to convince them, spit and let us know convincing them at 4:30 in the morning. So I said, now this will be too much if I'm there, next onwards it will 2 o'clock, we'll go somewhere. But when we wanted to do as a group society, when group of doctors meet, I thought we have a social responsibility. So this is where I copied a leaf from this program. Not the leaf, sir, whole booklet only I think I have taken it. Yes. So this program, we wanted to launch in all over India level. Since we have manpower, since we have department, so that is why we thought we will have this program, Oral Cancer Mukta Bharath. In the sense, we are planning to, from the IOMR, this particular program, what was done successfully in Yenepoya University, we thought whether we can percolate it down all over India. It will be a sincere effort from me, sir. Now, before I conclude, though it's an official program, I think I would like to make it a little bit personal. So honestly, Tashika introduced me, so I was just thinking, okay, whether it is me or not. Anyhow, she introduced me. If at all this, a little bit of part of the credit goes to my wife and my family also. Okay? Thank you for tolerating me and adjusting me with me all these days. No, sir, this I'm taking an anticipatory bail because next 1 year I will be out of the house. It is, no, this is a little bit personally, anticipatory bail. So because as a president I will be.
You are not taking it very seriously. You should have told because of them I'm there.
Yeah, that's a part of it. So because I have to go home. So I was thinking, like, whether in this lot of people online, lot of people online they are saying, lot of people are sitting here, but still at the end of the day I have to go home. So I thought, let me give that credit. So another person I would really like to thank is Dr. Lakshmikant Chhatra, a principal of ours. He is the principal with the principal. Okay. Always sometimes he used to tell me, like, there are certain things, see these rules, all this, there are some certain things in life, they have to be self-disciplined. It cannot be told to a person. It has to be self-disciplined. So he's a man like that. See, he was also actually, yeah, and he was there with us, we were working together. It is not that we didn't have a difference of opinion. We had. But in an appropriate time, we diluted that in appropriate media. Okay, we had a discussion. All those differences were either diluted in an appropriate media or it was burnt out. So some people will get what I said. Okay. So there was a connection. Thank you, Dr. Chhatra, okay, for your wholehearted support. So thank you for all of the people here who have come here, and thank you the organizing committee for again associating with the IAOMR. We will definitely do the good. Thank you.
Thank you, sir. Now I request our respected Dean, Faculty of Dentistry, Dr. Shyam S. Bhatt, to kindly present the memento to our guest of honor, Dr. Prashant Shenoi, as a token of our appreciation and gratitude. May I now invite Dr. Nikhil Raj, an alumnus of Yenepoya deemed to be university and EC member of the Indian Association of Oral Medicine and Radiology, to kindly take the stage.
Good morning all. Good morning respected dignitaries and teachers and my dear friends. As a proud alumni and a grateful student, we take this wonderful opportunity to facilitate our dear respected teacher Prashant Shenoi sir, as he became the National President of Indian Academy of Oral Medicine and Radiology. It's a truly honor moment for all of us. Sir is an excellent academician and exceptional organizer. His leadership was clearly demonstrated when he served as a conference secretary for IAOMR conference held in Mangalore 2014 and 24. Please, all the alumni from Yenepoya, please come over on the stage. Please. It's my request. Continue. Yeah. He is an exceptional leader who was clearly demonstrated when he served as a conference secretary in IAOMR conference Mangalore in 2014 and 24. Each is conducted with a remarkable success. He has also been highly active in Indian Dental Association, as Tashika ma'am told. He served as a Karnataka branch, both secretary and president, and contributing greatly to the professional and its development. Beyond his all achievements, He is a wonderful human being, always inspiring his students. With immense pleasure and heartful respect, we alumni wholeheartedly felicitate our beloved Prashant sir and became him a continued success and good health. Thank you, sir. So, moreover, we are very happy to share our
on our esteemed principal, Dr. Lakshmikant Chatra, to address the gathering.
Good morning. Good morning, ladies and gentlemen. Respected chief guest of today's function, Dr. M. Vijay Kumar, Pro-Chancellor of the Yenepoya University. Dr. Akhtar Hussain, Secretary, Islamic Academy of Education, and former Dean of the Yenepoya Dental College. Dr. Prashant Shenoi, President of the National Indian Academy of Oral Medicine and Radiology. Dr. Shami Asbad, Dean Faculty of Dentistry. Vice Principal of Yenepoya Dental College, Dr. M. Mohammad Hassan Sarfaraz. Dr. Maji Jose, Dean Student Affairs, Yenepoya Deemed University. Organized Committee Chairperson today, Dr. Rachana Prabhu. Secretary Anubabu, Professor of the Department of Psychiatry, Yenepoya Medical College, Dr. Anil Kakunje, Professor and Head the Department of Oral Medicine, Dr. Raghavendra Kini from AJ Shetty, Dr. J.P. Anekal, Jayaprasad Anekal, the Professor and Head Department of Oral Medicine Radiology, Sulya, all my colleagues, students, participants, ladies and gentlemen. We are here on the occasion of the Oral Cancer Mukta Bharath is being conducted by the Tobacco Cessation Cell of the Yenepoya Dental College in association with Indian Academy of Oral Medicine Radiology. This particular initiation was started in the year 2017, wherein Dental Council of India made it mandatory to have the tobacco cessation cell in each institution under them. With this notion, we have started the tobacco cessation cell in the Department of Oral Medicine and Radiology. According to the Dental Council of India, it is mentioned that it has to be taken over either by the Oral Medicine Department or the Community Dentistry. It has to be along with next to the reception area of the college. with these restrictions and felicitations, and we have started this particular program in the year 2017 under the leadership of Dr. Sripati Rao, then the Dean, and Dr. Shamya Spat was the Vice Principal. We have initiated this particular program as Tobacco Cessation Cell. In the inaugural address, Dr. Sripati Rao said it should not be only the namesake Tobacco Cessation Cell, that the DCA says you should have some program associated with it. So we had the programs right from the beginning, from the day one. We made the Dr. Rachana from the oral medicine is in charge, but we had a panel of members along with it, from the oral medicine radiology, from the community dentistry, from the Center for Substance Abuse and Prevention, then from the, it was a university program. So we initiated this particular program, went on, and with the criteria set by forwarded by the WHO. So I just want to remind a little bit about the WHO. What it is. This initiation was started way back in 2000, where the WHO initiated the Tobacco Control Program, Tobacco Control and Prevention Program, way back in 2000. India became a signatory to this particular issue in the 2003, and it is ratified in the 2004. What does it mean to us when you are signatory to these WHO recommendations? That means you need to implement this particular program as a tobacco control cell in India. That's how in 2005 Indian government have started the tobacco control program. Of course you cannot have any control over the manufacturing and selling, but you need to have control over prevention, usage of this particular tobacco products. That's how all these things have started. Though we have the almost 38,000 primary health centers in India, but we cannot be able to introduce this in the primary health care centers. That's why they said that NMC, that at that time it's the Medical Council of India, Dental Council of India, is given a chance to implement this in their institutions. That's how this being started from the beginning. That's how it instituted. First one to introduce this is the Dental Council of India in 2016-17, and the NMC, that is New National Medical Commission, introduced this particular center in 2005, last year. It is made compulsory for NMC, each and every institution in India to have a tobacco cessation cell in their institute. Merely having a tobacco cessation cell, we cannot be able to have anything further down. That's why we had the initiation program by our tobacco cessation cell. Whoever comes over to the institution is taken care by the oral medicine radiology department. In the community level, activities is done by the public health dentistry. In an institution level, university level, it is done by our other cell, which is used by the our university level. But we never had any programs as such, even from the 2017. Now, this is the first time we having this particular program as under the Tobacco Cessation Center. So when he brought out this particular thing that we never had a program, then Dr. Prashant Shenoi, National President of the IOMR, said we'll have this program, it's a national level. So that's how this program is being conducted today. I thank each and every one and made it possible to have this particular program today under the banner of Tobacco Cessation Cell. It's in college cell. To have this particular program, to inaugurate such a program, we have a wonderful person with us today. Dr. M. Vijay Kumar, an oncosurgeon, far excellent administrator and orator. And he's with us today in spite of his busy schedule, agreed to be here with us today on behalf of the entire dental college and the fraternity of the IOMR. Sir, I welcome you, sir. Thank you for being with us today for this particular program. And he'll going to consent to give the guest lecture on this. At the same time, I thank the National President of the IOMR, Dr. Prashant Shenoi, given us an opportunity to have this particular program in a national level. Thank you, Prashant, for your gracious presence today and given us a chance to be with the National IOMR. I thank each and every one. They left their job and came here and sat for this particular program. Hopefully, this is going to be a good program so that we can able to not only cultivate this particular program, implement this program in your institute. One last thing I'm going to say, all the faculty members, those who are participated online from the IOMR faculty, thank you very much for being with us. Yenepoya Dental College in the forefront in this particular area always, and we'll be doing to do so the same thing. One last thing I'm going to tell all the the IOM member is that make sure that each time when you see a patient, please tell the patient to do the self-mouth examination each time, so that any changes in the oral cavity can be detected early, can report it to the oral medicine person or any of the dentists as early as possible. That's how we can able to prevent the progress of the lesion in the last stage. If it comes in the last stage, it's very difficult to treat the illness. Kindly take this as a pledge. You implement this throughout the India so that each and every time we teach a student, please teach the student, take 2 minutes of time to do the self-mouth examination. Teach how to do a self-mouth examination to the patient at your chair side. Thank you very much and have a nice day.
Thank you, sir, for that insightful speech. May I now request Dr. Rekha P. Shenoi, Professor and Head Department of Public Health Dentistry, to kindly introduce our esteemed chief guest for today's program.
Thank you, Dr. Supriya. Good morning to all the dignitaries, colleagues and students present on stage, off stage and online across India. It's my privilege to introduce the chief guest of today's program, the Honorable Pro-Chancellor of our university, Dr. M. Vijay Kumar. In addition to being the Pro-Chancellor, sir is also the Director and CEO of the Zuleika Yenepoya Institute of Oncology and the Yenepoya Technology Incubator. Before this, he served as the Honorable Vice Chancellor of our university from 2015 to January 2026. Before joining Yenepoya, sir was the Director of the Kidwai Memorial Institute of Oncology in Bangalore, where he served for more than 31 years. He has held numerous positions of distinction, such as the Honorary Secretary, the Karnataka State Chapter of the Association of Surgeons, President and Honorary Secretary of the Indian Association of Oncology. He was deputed by the Government of Karnataka to study the National Health Scheme of the United Kingdom to incorporate into the Vajpayee Arogyashri scheme. He is also the Chairman of the Task Force for Health Promotion and Prevention in Oncology under the National Cancer Grid under the aegis of the Tata Memorial Hospital, Mumbai. He is the Governing Council member, the Board of Management member, and the Academic Council member of the Association of Indian Universities, the Adyar Cancer Institute, and the JSS Academy of Higher Education and Research, among others. Sir has more than 100 orations at the international and national level. Notably, Sir Dorabji Tata Oration has directed more than 90 research projects and has more than 90 national and international publications and books to his credit. He is a PhD guide, an MCH guide, and an MCH and a DNB examiner. He is the recipient of several awards, notably the Dr. Mahadevan Award, the Terry Fox Project. He is the honorary member of the Brazilian Society of Surgical Oncology. He has been invited as faculty for the European Society of Surgical Oncology and the guest of honor by the British Association of Surgical Oncology. He has been honored as Professor Emeritus by the Rajiv Gandhi University of Health Sciences. In 2025, Sir was honored for his lifetime contributions to cancer by receiving the Healthcare Excellency Award, which was given by the Kannada Prabha and Asianet Suvarna News, and the Icon of Cancer Care Award by the PSG Institute of Oncology at Coimbatore. Sir is an acclaimed surgeon, a dedicated academician, a committed researcher, and a passionate teacher and orator. Closer home, his visionary leadership has transformed the Yenepoya University campus. With the help of the Tata Trust Grant in Aid, he set up the Zuleika Yenepoya Institute of Oncology, where patients from all across our state and other states in India receive the best treatment facilities at the lowest cost. He established the Yenepoya Technology Incubator, fostering over 58 startups and more than 200 innovations. He is the principal investigator for the state government Ministry of Youth Empowerment and Sports projects which have been taken up on tribal populations on both nutritional status and also NCDs, which has been implemented in more than 5 districts across Karnataka. He is also the principal investigator for the ICMR project, which was awarded to 6 institutions in India, out of which ours was the only private university, which is for implementation research for screening, early diagnosis and initiation of treatment for oral, breast and cervical cancers. He has established the state-of-the-art robotic surgery unit at Yenepoya Medical College Hospital, which has 2 advanced surgical robots. And he was also the mastermind behind the establishment of the Advanced Surgical Skill and Enhancement Division, which is used to train surgeons in cutting-edge minimal invasive technology. Through the Cancer Awareness Outreach Program, he has trained NSS volunteers, program officers, ASHA workers, Anganwadi workers, and nursing students, as well as the faculty of Yenepoya, deemed to be university, to raise community awareness of cancer. Working with the Rotary Club of Mangalore and Silicon Valley, Sir has launched the Women's Wellness Clinic, which is a state-of-the-art screening tool for cancer. Also, Sir directs the WeCan project of HPV self-testing, which has made cervical cancer screening accessible to women in remote areas. His students call him principled, empathetic, no-nonsense, and a great teacher and administrator. Working with him has been a privilege. For the support I have received, for making me a more prepared professional and a better administrator, I thank you, sir. Today, Sir is also our resource person. I now request him to address the gathering. Thank you.
Good morning, everybody. As they are settling down in the dais and the stage, at the outset, I am thankful to the Yenepoya Dental College, the Tobacco Cessation Center of the Yenepoya Dental College specifically, and Indian Academy of Oral Medicine and Radiology, first of all, for doing this program, and second, of course, for inviting me to be a part of this program. It's indeed nice to see people offline as well as online, and I'm thankful to those who have joined online in spite of their busy schedule in their own institutions and practice. And I also see some of my colleagues from other dental colleges here. Welcome to all of you, and my thanks for taking time off and coming to us. One request, please put your mobile phones on vibration mode. This is what they say, that in a different way when you enter the flight, flight mode. So if it is flight mode, it will be too much, so at least vibration mode. Because we are online, some amount of discipline, let us say. If it is only ours, I'll be talking in a different tone. I know I'm talking in front of so many other people. Let us show that Yenepoya is disciplined also, apart from organizing well, right? They asked me to talk on this subject, which has come as actually a little surprise for me, because they were asking me to do something on what the dentist should know about it, or what is their responsibility. Suddenly they are making it as social responsibility. In a lighter sense, I thought, no, then the dentist's responsibility is social responsibility. And social responsibility is dentist's responsibility. I don't know. I don't know whether you people are understanding my English, because they are all very blank. It's supposed to be a joke. So, okay. Right. As we are going now, I'm going to the little more serious mode. See what is happening here. This is not a textbook picture. 41 years back when I joined Kidwai, I used to see this. So I thought we have to do something, and we have been doing. But this is our picture, our place in Zuleka last year. This is really saddening for me, at least, because I thought that I am fighting oral cancer, blah, blah, for the last 41 years. Some impact will happen. But this is the presentation last year to our institute itself, Yenepoya, Zuleka Yenepoya Institute of Oncology. Forget about government sector, forget about this. So I was asking my question in this photograph when I wanted to place, whose responsibility is this? Is it individual's responsibility? Is it the family responsibility? Is it the friends and family keeping quiet? See, this simply on the face. Where is the question of telling I don't know? So I don't know what we have to do on this. If this is the type of presentations, although we are going on, working, talking, everywhere we are talking about it. So the responsibility lies with everybody is what I thought, and that is why this ghastly picture, knowing it, I have put it, because it is not a joke or it is not a foregone things. This is happening today in our own setup. So we should be knowing about the responsibility. I mean, we should know what is happening to our country as a whole. Most of the time, if you look at the textbooks, as well as anybody, any student, if you ask, they'll be talking about the data from Western countries, because they used to say, Western countries have data, we don't have. SEER data for everything, for example. SEER data is from US. Whereas we have our own data, it's called NCDIR, National Center for Detection of Information, Diseases and Information Registry. It was earlier called National Cancer Registry Program, NCRP. Incidentally, it is located in Karnataka, in Bangalore. It is headquartered. It started from Kidwai, it's a small center, then they moved. It is a part of ICMR project. You know what is ICMR, Indian Medical Council Research. So this, if you look at this data, I am coming to that. The tumor burden, you will be wondering why tumor burden of oral cancer I am talking, because it's very, very, very difficult to even digest that we are contributing to 1/3 of oral cancer burden to the world. I thought we'll do something good, but we are doing it on the other side. We are contributing from our country 1/3 of the burden. It's a big, big number. I don't know whether you're able to even understand what I'm talking. 1/3 is 35%. And out of that, if you see, whoever is coming, in fact, when I was heading the Department of Oral Oncology at Kidwai, I used to see 1,200 to 1,500 oral cancers biopsy proved. That was the situation, and out of which not even 200, 250 will come to the table and see the way the stage they are presenting. And I thought only Kidwai is happening? No. The same data comes now. You see, only less than 30% of the oral cancers are detected early. That means 70% of them are coming the stages which I showed. That's very ghastly picture, you may say, but the stage 3 and stage 4 even today exist. See, there are different ways of educating people, telling that please do that. This ghastly picture I showed only to hit you on your face that don't allow this to happen. It is in our hands. I'll come to that later, but how we are going to work on it. But we are part and parcel of this happening around us, and we are mute spectators is not the right way to do. And of course, individual responsibility, I refuse to come if I am a patient, then we cannot drag him out. But unfortunately or fortunately, we are also silent on over a period of time. So that is why I said that. And second one, you see, is it only the stage of the disease we are talking about, coming early, coming late? What is going to happen if they come early or late? All of us know, sitting here, knows when they come late, the results are poor. That we know. When they come early, we are going to detect early, we are going to cure more. When they come late, cure less, and probably not cure at all. But that part of it has been put in our textbooks, and all of us have been drilled every day, that part of it. But look at the productivity loss. See what is happening to the productivity loss. We are contributing, again, India is contributing to 2/3 of the mortality due to cancer in the world. 2/3 is almost 66%. And what are we sitting here and talking about early detection? I really don't know. I ask myself because I'm doing that for the last 41 years. And what have I achieved? I really don't understand. But anyway, we have to know these things for at least the younger generation and the people who are listening to me to take the cancer part of it seriously, not only the non-cancer part. So that is what my today's plea, whoever is listening to me, both online, offline, take cancer seriously. The productivity loss you see, mortality you see the way they are presenting, it's all in our hands most of the time. So we have to do our bit. See, you will look at the money lost for the country. Money lost. In spite of whether it's the early stage or the late stage, the premature mortality caused by the oral cancer death is resulting in what? They are talking about billions, 5.6 billions. And the last prematurely because of that productivity loss is around $41,000 to $96,000. It's in dollars I'm talking. So there is a case for all of us in front why we have to catch them early. It is not just early stage, it's not textbook description, you catch early, we cure. No. We are still facing the problem. So the only way to avoid this sort of productivity loss, premature death, and contributing to in the negative sense, to the world from the point of view of oral cancer death and oral cancer incidence, is only way is to do prevention. That's what today I am going to concentrate on. I only made a baseline. If somebody is sleeping, they should get up. So that is what it is. We all know this. We all know this. All of you sitting here, I'm sure you know what is primary prevention, secondary prevention, tertiary prevention. That is not the point. I am only going to share to all of you what we have been doing in Yenepoya. I am not going to give you what should be done by you, but I'm going to talk on what we have been doing for the last 1 decade, and that is literally a fight against the oral cancer. 1 decade of Yenepoya's experience is what today I'm going to share quickly on preventive aspect, because they are talking about prevention today. We are treating also, that is not the point of discussion today. So with respect to primary prevention, as I said, it is more of health education and health promotion. What are we doing? We have joined with the district administration, etc. We are sitting there and doing all these tobacco prevention activities by creating awareness across Mangalore, across the Dakshin Kannada. This is what we have been doing as far as the primary prevention is concerned with respect to schools. Coming to the secondary prevention, this was touched upon by my previous speaker, that is Dr. Prashant Shenoi. But anyway, we have to know a little more elaborate, because we did something more in this arena, in this area. As I showed you that when we came, why it was late presentation. Back in Kidwai, when I was working, we used to see 120, 130 cases per day sitting. When I got up from the OPD, neither the patients are happy nor I am happy, because most of them are advanced. At that time, the data was 88% of them used to present late. So when I reached Yenepoya, then I thought we have to do something, because I saw there is NSS very smooth and well-oiled organization in a very properly organogrammed, supported by state government, supported by central government. So I used that, and I called them, as Dr. Prashant said in a jocularly, but I don't know how many of you listened to it properly. I just said, will you come voluntarily? I never bothered who they are. There are nurses, there are dentists, there are MSWs, there are, of course, doctors, everybody. I said, who will come to voluntarily take up this part? As he rightly pointed out, first day I saw 50, 60 people. At the end of the day, the way I speak now, when they speak to them, what will happen? Only 6 of them stayed back. So, but that 6 of them then grew to 10 or 12, and they stayed with us, with me, even today. And I'm thankful to every one of them. Some of them are here, some of them are not here. That is how we started working with NSS, Government of Karnataka. We were only 4 units, the colleges at that time in Yenepoya University, medical, dental, nursing and physiotherapy. So it was a small unit. So I approached the Bangalore University. They immediately joined us with the NSS, and then we approached together 3 districts we covered for creating an awareness. We didn't do anything except creating the awareness to the NSS people. We trained volunteers, the program officers, and the program coordinators in 3 districts. 3 districts is the jurisdiction of Mangalore University. That we didn't choose, it is the university's jurisdiction. Dakshin Kannada, Udupi and Kodagu. And that's what we did first. After seeing all this, suddenly Government of Karnataka woke up and asked me, why are you doing only for 3 districts, why not do for the whole Karnataka state? They wrote to me. Then I just checked how much we have to do. Then I said, no, it's not possible to do for the whole state of Karnataka what we are doing here, but we'll modify it. Then we modified it, and 4,000 program officers, coordinators of 40 universities of Karnataka, we trained them and make them, it's a TOT, training of trainers, then we make them go to the NSS volunteers, and through them they go to the camps and they start spreading about that. And the next part is when I came here in a little lighter sense, I thought I'll manage with my broken Kannada here. But then I realized there are seven languages we are speaking here. It's much more than in Bangalore. That is, Kannada, English is one side. Then it comes Tulu, Konkani, Bari, Malayalam, Hindi. So we were wondering what to do. Then we developed the IEC material in English and Kannada, but it was dubbed into all 7 languages so that it reaches the rural. The language what they wanted, we were able to tell through the CD and gave the CD to our NSS program volunteers so that they go. Now the best part is, again, they should know some lighter tone also. Very seriously I'm going. When I first asked them to come, yes, you prepare. The team which I created prepared and come. They started giving like this what I am doing. Classroom lectures for them. I said, nobody will sit here. We are talking to rural people. You should not talk beyond 10 minutes and it should be more pictorial and it should reach the public. The communication should reach the public. Then that made them, poor people, run away. But few people stayed back. Then we validated that and then we gave that CD in 7 languages. It was made. That is what we did. And once we did this, we thought, why only NSS people? Then why not the school children? That is where Dr. Rachana Prabhu came into the picture, and then she was ready to take it to the school children. Then Dr. Imran came, and he likes nursing students. So he took nursing students. So Imran Pasha took the nursing students, and she took the, anyway, his wife is there. So the 9th and 10th class students are there. So when this is what we started doing, and we just creating awareness. That is a part of the primary prevention. And this is what the telltale story of what we did. And that numbers speak for itself. Around 13,500 people we trained the students. And then the 135 people, volunteers, NSS program officers, etc. trained. This is a story. Once we said it, then across the state of Karnataka we went and we trained every one of them, the program officers, 4,000 people. And because of those things, of course, the NSS got the best award in the state, not once, best award for individuals like Imran. All of them got it 3 times only through this program. And it was well appreciated. Stop now. This is what we did, I said. So what whoever is listening to me as a dentist can do. That is important. I cannot be going on telling I did this or we did this. That is only to prove a case that we are not talking theory. We are telling you what we can do. And I always have said, when we can do, anybody else can do. If anybody else can do, we can do. So that is the reason for which we are trying to talk about what we have done. Not to tom-tom. Of course, the surgeons believe in tom-tomming, showing off. But that is one part. But remember, when we can do, anybody else can do. So the dentist, what they can do? Sir, we cannot go to the public and do. I am not asking you to go to the public and community and do. When they come to you as patients, they come for simple scaling, simple toothache. You can always see the stain on the tobacco. Can't you tell them? Don't use tobacco. One line. I am not asking you to lose the patient by telling sermons to them, but you can always tell 1 minute extra, tell them don't use tobacco. No? That's as simple as that. And if you are a regular patient, definitely they will give more respect and more reverence to you and accept you rather than me going there for a suddenly and tell don't, who are you, they will ask. Whereas you are their dentist, you are their doctor, they will listen. That is where this stands the role of the dentist in primary prevention. Let us go to the secondary prevention. What is secondary prevention? It is screening and early detection. What have we done here sitting in Yenepoya last 10 years? Again, from COP awareness, we moved slowly toward the screening part. But to go to the screening part, what is happening is we have to do something possible. So that is where, we'll come back to this, the Rotary Club came into the picture. Rotary Club of Bangalore and the Silicon Valley International came and said, you are doing all that. See, you must also know that people are watching you. Not only good and bad, whatever you do, they are watching. I didn't approach them. It is the Rotary Club we approached us, saying that you are doing all this. We heard, can we help you in any way? I am a very good beggar, you know. So immediately I said yes. And that is the answer we got. This is the bus which was specially designed. And you can take this bus anywhere today. And we can go to the rural. We are going to the tribal. I'll come to that. We go all these places because it is self-sufficient bus. We have got a generator inside. Everything is inside. We need not worry about water or electricity from outside. And that is how we are designed, so that we can go to the rural. And that is what happened. Because of this, we are able to do the training not only for awareness, we started doing the screening. And after all, for oral cancer screening, that big bus is not at all required. I just showed the bus because I want to show top-down. But basically, it is oral cancer doesn't require anything, if you ask me, except for a good torchlight. Nothing else is required. Unlike a mammogram for breast and PAPs or colposcopy for cervix, it doesn't require anything. That's one more thing all dentists listening to me should know. We are at an advantage. You are at an advantage. What you require is a good light and nothing more. And when you do this, what we did was, then we said we have to reach them. So how do you reach? So we started thinking of going through the Asha and Anganwadi workers. And Asha and Anganwadi workers of the Udupi district, thanks to the then DC, who was Dr. Vishal, is a doctor, medical doctor, whom I approached. He supported me, and Dr. Abhay Nirgude and I myself wrote this, and then we went and 2000 Asha and Anganwadi were trained to not only creating awareness, but to screen all the 3 cancers. When we did it, then suddenly I asked myself, are we in the right line, or are we simply doing for the sake of passionate about it? Then I approached the Tata Trust to ask them, I want to know what is the impact it is creating. So then the impact analysis was done. They gave us around 62 lakhs for doing that project, and we did it. I didn't know at that time how this is going to blossom into something bigger. That's why I said it's 62 lakhs intentionally. Then at the end of the whole thing, when we did the impact analysis, we spent around 50 lakhs, and remaining 12 lakhs was there. And so very sincerely, I sent it back. And when I did it, I thought I'm doing my job. That resulted in a much, much bigger impact than what we created there. Then the Tata Trust said, what do you want from us? We will help you to do something more. When they are doing screening, where do you want to treat them? I said, no, we don't have radiotherapy, etc., etc. And that is the genesis of the Zuleika Yenepoya Institute of Oncology. They gave us, they came, they built, and hand over the best of the treatment today. And the most important thing is, because it's only for prevention, so I'm not expanding there, but we are treating 95% of the patients who are coming to us all below poverty line, free of cost, under schemes. Because they gave us free, and when I told this to my Chancellor and Pro-Chancellor, Mr. Dr. Abdullah Kuni and Bharath and Yenepoya, one-line answer they gave. Anyway, you brought it, see that it is the most affordable in the country. I think many of the private management will not say that. I have to definitely say that on public, that they told me and said, no, it should be the best, you brought it, but it should be the best and most affordable. So that is what the point is. 95% of them are getting treated totally free. They have to only show me the card as per the Ayushman Bharat, and that is what had happened. It all started with this journey. That's why I am trying to say all this. And then the government, again, as I told you, governments, everybody is watching. Again, government approached me saying that you are only doing for rural, why not you do it for tribal? I said, yes, there is a bus, I can go. And last 5 years, we are working through the NSS department, that is Department of Youth and Sports, Government of Karnataka. For last 5 years, they are supporting us. We are now doing the tribal population NCD screening. That is oral cancer, breast cancer and cervical cancer, plus diabetes and hypertension and anemia. We are doing all that for the tribal population. I don't know how many of you have ever seen a tribe. It is not rural. I'm telling you, tribe. There is no road. There is no electricity. There is no water. There we have to go. I'm thankful to the team which is going there, headed by Dr. Ashwini Shetty, who was ready to take a team and go there. Day in and day out they are doing. And this is the number we have already covered. You see the numbers which we are covered is around 11,182 beneficiaries, of course all cancers, including oral cancer. 3 cancers of course, and including oral cancer. This is what we could do. And once we are doing that, the government is supporting. Government supporting a private institution is rare, you must know. The money is very small. They give me 30 lakhs because it is official, so I can tell the money, 30 lakhs. With 30 lakhs we can't do that. It is department support, institute support, university support, and the management supporting this could happen. But the most important thing is the recognition given by the government. Government coming to us when there is big centers are there and asking us to do. The last 5 years, we are covering 5 districts: Dakshina Kannada, Udupi, Kodagu, Ramnagar, and Chamarajanagar. We are continuing to do, and they are very happy with us because the result, one thing I gave it in writing was, if anything we detect there, I will bring it here and treat totally free. Probably that is what that made a big impact on them, that totally free. We won't ask any questions. Anybody screened in any camp here will be totally treated, free of cost. Again, this is what we are doing, I said. Then what can the dentist do? I think dentists can do much more than what they are doing. See, the early detection of pre-malignation, as somebody said, I think it's Rachna Prabhu, in the morning, that you just open the mouth, just see, you can pick up lesions which could be prevented from going towards malignant. That is one advantage in oral cancer we have. 90% of the time or more, there is a pre-malignant lesion, there is a pre-malignant condition, there is a pre-malignant phase where you can catch them so that you can prevent them from moving towards an invasive cancer where it becomes catastrophic. So that is one thing which you can do. You need not be an oncologist for that. You need not be anything. Ask them to open and you are going to see that. Even if you suspect, send them. I'll tell you the suspect part of it when you say, see this here, this side. We have referred about 681 cases, everything, out of which you see the suspected one, 4, 11, 35, that's all. You are also going to see only in a very few numbers. So suspected, out of suspected you see about 60 it comes to. Confirmed cancer cases are only 2. So out of 4 out of 100 only in our series, what we are suspected turning out to be cancer. So you should not shy away. You are suspecting, people should not ridiculously saying that it is not cancer. Let it not be cancer. That is their headache. If you are suspected, you refer to us, refer to anybody. Ultimately, when you suspect, you must see that it is referred to the next place. That's what the theme should be. Look, feel, and refer. You need not worry about it, whether it turns out to be anything. But here what happens, many times, maybe our social thinking plays. You should think about good things. You should do good. All these are social. Professionally, you should do correct things. If you don't think every ulcer has to be aphthous ulcer, every ulcer to be traumatic ulcer, go on filing the dentition. That is what many times many people are doing. So think, if it is not healing, remember it could be malignant, then refer them, rather than keeping them with you for changing the antibiotics after antibiotic. You have to change your diagnosis. So that is what happens. That's what I am trying to tell all the dentists, that you should play a major role here to catch them early. This is what I have been already telling you. When to refer, anybody who want to refer. This is what happened, the Comprehensive Health Center. We started at 0. Today we have got 70 people working for us. All faculty members only I am telling here. This is 70 people as a faculty members, and all started with 0. So you can always grow and move. Today we have got the best of the institution with the most importantly the state-of-art care given by Tata Trust and being given free of cost by the management. This, why I showed is, it's not a prevention, but again I have to tom-tom when given a chance to you. Though Dr. Rajna Prabhu said only prevention, but I won't get a chance to talk to the people who are national, no? So I am going to see what we are doing. And so the impact of early detection we all know, but we'll come to this. What else we are doing as far as the prevention is concerned? Here, about us. Already that was told. One ICMR project came, about 184 people wrote. I don't know how many of you know. ICMR wanted to know, when the NCD program is there, Government of India is supporting, why it is not getting implemented. 10 years, more than 10 years, that is not getting implemented. They wanted to know why. They are curious to know why. So then they asked us to write an expression of interest. We wrote. One of the 184 people who got selected, applied was we. And out of 6 people, we are one among the 6 selected and the only one from private again. All others are central institutions. What are we trying to do? We have already finished 1 year. This is called as formative phase. Implementation research, where why not detect early? Why not initiate treatment? This is the question asked by ICMR, and it's an implementation research which is going on in Dakshina Kannada. The second part of it would be, as I told, that we are working with the community base that I explained to you in detail, and seeing that, of course, this is not oral cancer. They asked us to work with specifically with the nutritional status of the tribal women. That is another project they gave us, and we are working on that. The last but the least is the most important one is, can you imagine not only government coming in, one more corporate coming to us, Azim Premji Foundation, saying that we will help you do something. So December 1st, 2025, we started, not officially, informally, official inauguration has not occurred. In Brahmavar Taluk, we have started working on early detection of oral cancer, breast cancer, and cervical cancer across the population. Why I am stressing on that is, till now we have been doing campsite. We go, choose the cohort, and we do it. That is what is happening. It's called as opportunity screening. Whereas what we are trying to do is organized mass screening program, totally free of cost, thanks to Azim Premji Foundation. They are giving us, and one taluk has been taken, 2 lakh population, 1 lakh is adult, and eligible population for about 35 years is roughly around 70 to 80,000 people. We have started doing that totally free of cost for them, irrespective of who they are. We are not going to even ask whether you are below poverty line, APL. Such questions are not asked. Adult willingness, then we are going to do. It just kick-started December 2025. This I wanted to tell, Dr. Akhtar Hussain plays a major role here by bringing it first from Delhi. But probably I don't know whether he goes now to see what is happening there. The second part is, I'll come to this part a little more. Why I am telling this, I'll tell you, because my colleague from other places are there. This is nothing to do with prevention, but I told you I have to tell this, taking the opportunity given for extra 3 minutes, that this is what we are sitting and doing today, apart from what others do. And it is meant not only for us, it is for others also. See, this is a PEEK. PEEK is polyethyl ether ketone, of course, operated by me. This particular case is important this is the first case, that's why I am talking, like a first child. This is the first case. The polyethyl ether ketone, that's where you are getting, that is a non-metal material. It's a biocompatible material, but nobody has used it till that time in a full-blown hemimatable prosthesis. It's a patient-specific implant. And it was 3D printed. What is special about it, if you ask me? Hopefully there were oral surgeons here. Otherwise, this patient, you see that side, the OPG there. 2 times they have operated on her for a mammoblastoma. One side left, then mid-segment, and they have used the fibular microvascular. That is the right thing to do. But she came to me, this was the scenario, but she said, she's a staff nurse incidentally, she said, sir, I know you have to remove, but you remove it, but I don't want my body part to be touched otherwise. That she was worried about the fibula they removed. Then I said, no, without removal is okay, but I have to do something back. No, you do whatever you want to, you should not touch my body. I said, fine. Then we are working on PEEK. Are you ready? But it is not yet ready. We are not approved, validated. She said, please do it. That is how we did it, and you see the result there. The most important thing which is exciting me as a surgical oncologist is, whenever we have done this, as they have done rightly, we should have called somebody else, or you have to do a microvascular free flap. That means 3-4 hours of extra surgery, extra burden, etc. If only my theory goes on, the person who resect like oral surgeon, anyway, he has already got a implant ready, specific implant, all shape, size, nothing he has to do. He has to put it and put plate and screw like a trauma, and the whole thing comes out. I hope this comes through completely. We are just validating. If it comes through, it is a breakthrough in the costing of the treatment, expecting a microvascular facility available. We do it here. We do it around 500 cases we have completed in last 10 years in microvascular free flap, but it is not available everywhere. And even if it is available, why should you do when simpler things are available? So this is the process which we have started doing. That's why I showed. This is not mine, but I don't want to tell whose it is. It's some other dental college approached us. This I am telling because only cancer I am talking, even for non-cancer, you see what is happening. That is the, you know that is 3D in the virtual, then on the parop, and we have put it, most importantly, this is the final result. If this sort of final result can be given by our team, that is, we have manufactured and sent, operated not by us. I wantonly put the slide because people approach us, one of the neighboring dental colleges asked me, we did it and sent it to them. They did it. I asked them to send the photographs to show to you people that we are not here only to do for ourselves. If you want to do, we are ready to manufacture and send it to you. And this sort of patient-specific implants runs in probably thousands or lakhs. We are doing it in a pittance from the Yenepoya. From where we are doing from this Yenepoya Technology Incubator, which is recognized by the Department of Science and Technology, Biotechnology, Biopharma, etc., etc. It is one of the only 4 centers recognized by Government of India for medtech facility. The other 3 you should know, IIT Madras, IIT Bombay, and CCAM Bangalore. We are the only one from private which has been recognized. Seeing all that, one more thing happened is, though I have not put it on the slide, Government of Karnataka asked us to apply for another incubator, which we got it. It is TBI, but it's not yet started. Just they have approved us, money has been transferred. We are just going for developing there and establishing it, and recruitment is going on. And there we will be moving towards not only health tech, but we are moving towards AI, because we spoke about AI. So we are moving towards AI. Already the people who are in Bangalore are approaching us, and we are doing something through Startup India already, AI with Startup India, not only oral cancer. I am talking in general. So the AI is also coming in a big way to Yenepoya through the TBI as well as Startup India. These are some of the things which we are trying to do, but we will be wondering for the PGs who are talking about, or you can click that QR code, you get the book free of cost. You click the QR code. It is written by my own colleague, Dr. Rohan Thomas, who is the oral surgeon working with me. And this guide, of course, on prevention it is. So this guide was been authored by me along with my colleagues, Rohan Thomas and also Nanda Rajneesh. Both Nanda Rajneesh was my student earlier. We have guided. If you are interested, kindly go through that. That is our contribution in the form of textbook for prevention. Take-home message is very simple. Oral cancer is preventable and detectable early. Dentists play a very, very important, critical role. More importantly, please understand, look, feel, and refer. That's what I'm asking you to do. Don't go to the place where the patient is complaining of. Look at the oral cavity. And then you will be able to find and help us in the battle of oral cancer. Thank you very much. You are welcome to ask questions.
Thank you, sir. Because since a lot of our online people are there,
yeah,
we have. I was telling that oral cancer Mukta Bharath. So this was a project which we were planning to launch all over India. So our idea was to use the oral medicine department, public health, or other departments, and involve some voluntary organization to do the screening.
yes.
Now, sir, what is the initial difficulties which you have faced? The teaching problems. So because now I first have to train our own people, saying that is why I wanted you to hear to motivation, because we have a success story in Yenepoya.
Correct.
So what are the other things invariably we have to take at? Government rules, law, all those kind of things, anything?
I will divide them into 3 I's. First I is individual. You are also talking about that. Individuals should get motivated. Individuals become passionate about it. That one I is important to start the whole thing ball rolling. That's the first I. The second I is institution. Whichever is an institution, it can be a small clinic, it can be a dental college, it can be in any organization. They should be convinced that prevention is better than cure, which all of us have been drilled, but we only talk, we don't follow. This is the second thing. And today you see, I'll be talking a little more. Anyway, they are all there in online, but still I'm going to talk what I want to talk. What happens, I'm trying to tell you. I was one of the core committee members for starting a National Cancer Institute way back, 15 years back. They started, Government of India giving them 400 crores to start the program, the institute. And they brought National Cancer Institute, Bethesda, New York people to come and advise us. The idea was it's going to be a research center with policy making. That's how NCI follows. And give money to other people also to research, NIH. But what happened, to cut short the story? The parliamentarians did not accept. They said it cannot be a research center. No, it has to be a hospital, some research. What has happened was that today it has happened. NCA has come in Jajjar in Haryana, about few kilometers from Delhi, because Delhi did not have a place. 50 acres of land was given by Haryana state government. But what started as a National Cancer Institute for prevention, policy making, research has turned out to be another hospital. This is our mindset. We don't want to do anything beyond treating. Even today we are only wanting to treat. We don't want to see that the treatment. I was telling somebody on that day, they asked me, last week I was there, sir, you are a cancer surgeon, why you developed this interest? I said laughingly, otherwise I will lose patients. I won't get patients if they come advanced. It will go to immunotherapy, targeted therapy, chemotherapy. It will not come to me at all. People like me will lose the job, I said. What I mean is that they have to come early to be treated properly. Who will catch early? Somebody else will do the job? Somebody is going to harvest the paddy and give you a cook and eat? No. Ultimately, you have to cook and eat. So it is our job to cook for ourselves and eat for ourselves. If it is not in the mic, I may tell something more crudely, but I am telling eating. Otherwise, I would have said something else. It is our job. Is it not so? If you are not convinced this is not our job, somebody has to do. Community dentist has to do, community nursing has to do, community medicine has to do. Why should they do? Ultimately, give the patients to us. That is how they look at it. So, the problem is that government level, money is given more for treatment even today. Why NCI? Ayushman Bharath. Is there any provision for screening and early detection for money? Answer is no. I was a part and parcel of that for everywhere. It's only give money. The coding is there for money. The coding is there for treatment. Coding is there even now. We pushed and added for palliation also, but not for screening, not for early. Right? Again, when Vajpayee Orgazied program started, much before Ayushman Bharath in India, Karnataka started Vajpayee Orgazied program, and I was the task force chairman for cancer. After 2 years, World Bank came because they gave the loan to government of Karnataka to reassess or review. Then I still remember it was 2013, and we projected there 5,000, I'm not talking oral cancer as a whole, 5,000 palliative chemotherapy. Then the World Bank consultant asked what happened to them. Nobody did not have an answer. As usual, because I'm task force chairman, I have to answer. I said, I don't know, but they would have dead and gone. What are you telling me? I said, it's palliative chemotherapy, dead and gone. Why so much? Then I told the data. 88% of the patients are coming late, and out of which most of them come so late that nothing could be done, so that is palliative. Then he got so emotional and asked, then why don't you do something? I said, you give money for screening. It's as simple as that. When you are giving money for treatment, palliative chemotherapy, etc., they gave at the time 80 crores, 80. I told the World Bank, why not to give for prevention and early screening? They become silent. So, why I am saying all this is unwillingness for the agencies, including government, non-government, everybody, to come pitch in for screening and early detection. They are ready to pitch in for treatment. Let us look at the NGOs. How many people are ready to do what Azim Premji is doing? Azim Premji said, we will come and do it for early detection. Whereas one more corporate, whom I know I approached, because it's negative, I don't want to tell the name. They said, no, Vijay Kumar, you are setting up the hospital, you tell me, I want my board there. I want my board. That's what they said. So these are all subtle things, you know. Nowhere it goes to the next level. Prevention and early detection will not be productive, saying that this many patients I treated, this happened. That's not happening. So all the funding agencies, I'm coming to that, the problem is, are not willing to pitch for screening and prevention and early detection, but they will be pitched for treatment, including government agencies today. Ayushman Bharath, Vajpayee scheme, everywhere, treatment is given money, but not early detection. What is the repercussion of why money is required? Then who will go and do it? Everything is ultimately requires finance. You have to go, and I worked out a cost of that van, that big van I showed you, to go say 100 kilometers, etc. What is the cost you think we incur? I at least worked out the cost. Anybody? Anybody? Per camp I am talking. Per camp. You have to work out, no? No, I am asking for the whole camp. Who will come for food? Who will give? So, it is 1,20,000. We have worked out the actual cost per camp. And lastly, 2 rupees is not the point. That such a big vehicle, I'm talking about the fuel efficiency, 1 liter of diesel will give me 4 kilometers. So, but it has to carry so many things on its own, right? So, this is ultimately it is finance. That's why I am telling so much in elaborate, let them all listen to me. Somebody has to pitch in and give money. And it is individual's responsibility, institutional social responsibility, and corporate social responsibility. All three, we talk, but somebody has to do the job. And that is where, when we did all this, again, I'm thankful to Rotary Club, which came forward, the Azim Premji, which came forward, Tata Trust, which came forward. So there's a success stories, but not all are coming forward to do that.
Thank you, sir, for that.
Lastly, you must learn how to beg. That's a beg. You should become a beggar. Because in one visit you go, nobody is going to give money. Nobody. You must know how to beg. Keep on going, pestering, persisting, as though you are going to do for your daughter's engagement. But ultimately it is for others. That is the one more thing all of us, when you are trying to pitch in here for prevention and asking for money, should know. Not only you leave the shoes enter, you leave your ego also out and enter. Then only things will happen.
Thank you, sir, for that insightful and thought-provoking speech. Now I request our principal, Dr. Lakshmikant Chatra, to hand over the memento to our Honorable Pro-Chancellor, Dr. M. Vijay Kumar, as a token of appreciation. Dear delegates, the program will now pause for a breakfast interval. We shall resume with session 2 after 30 minutes.
A small request for those people who are online also. So there will be around 15 to 20 minutes break. After that we'll continue, and the session will be on actually what we do in our department on TCC. Thank you.
think my bottle is here. Act like that. No hurry. No hurry.
I request all the delegates to occupy the front seats.
Yeah. Welcome to all. Just 2 minutes because there is another few people are joining there. Okay, so now the formal things they will do it. This again, I am talking to the people who are online. So there are some 400 now, and some people from Manipur recently joined. Fine. Okay. What I would like to say is, for all our IOM members in particular, see the TCC, what I'm seeing in all over our India, there are only around 7 or 8 TCC centers are very active doing jobs. And this particular TCC, it is as such, tobacco addiction, what we are talking about. And I have seen people are even doing private practice. It is not that, it is just of academic venture. It is the science which is totally a sort of a clinical science. It is not just an de-addiction, all this, it is not just a theoretical thing. It is a science by itself. It is a disease, literally a disease which you are treating. So the center, comes under your treatment plan. So a lot of, again, who are online, I just want to tell a lot of PGs who are there. A lot of time if you see, our treatment plan will write counseling done. Okay, it is not just counseling. The counseling itself is an art. Counseling itself is a science. There is a protocol. So de-addiction, it is a totally clinical subject. So the next, that is why we have a speaker now who's going to see the first speaker, sir. He spoke about the social responsibilities, what all as a dentist or whatever as a things we can do. Now what we are going to, the second session is the practical problems and how to handle it. Now to introduce, I'll further hand over to Apu.
It's my privilege to introduce Dr. Anil Kakunje, Professor of Psychiatry at Yenepoya Medical College, Mangalore. He completed his DPM from NIMHANS Bangalore and MD in Psychiatry from KMC Manipal, where he was awarded the Best Outgoing Student Gold Medal. He has contributed widely to academic writing in psychiatry, having edited and co-edited many books and written several book chapters. He has authored over 115 publications in peer-reviewed journals. Dr. Kakunje is a recipient of the Professor Raghuram Distinguished Young Teacher Award and the Young Psychiatrist Track Award from the World Association of Social Psychiatry in the year 2016. He has secured research grants from national and international agencies and serves as a mentor for Indo-US PRIAA psychiatry research projects. He currently serves as an advisor to the Indian Psychiatric Society Quiz Committee and South Zone Publication Committee. He is the Editor-in-Chief of Archives of Medicine and Health Sciences, Deputy Editor of Journal of Psychiatry Spectrum, and Field Editor of the Indian Journal of Psychiatry. He was instrumental in establishing the 24/7 Psychiatry Helpline at Yenepoya Medical College, operational for over 6 years. We are truly honored to have such an accomplished academician and mentor amidst us today. I now invite Anil Kakunje sir to deliver his address and commence his talk for the day.
Thank you. Thank you for the very warm welcome. All talks start with a standard instruction that switch off your mobile phone or put in the flight mode, as the previous speaker said. But then I would say the opposite, because I understand your mind. So I would actually say open your mobile phones. So we'll interact through your mobile. The younger generations, even the older generations, are keen to see everything on the mobile. And I don't want distractions beeping from your mobile, so I would actually request you to open your mobile. So take out your mobile phones and take out the Google Chrome. You can type on the Google Chrome KAHOOT and space IT, KAHOOT space IT. The spelling is here, KAHOOT. Even the online people can do that, so that we can interact very personally, because the interactions KAHOOT space IT, it will ask for a game pin, and there you type this number 481109, 481109. You can write it down somewhere. If you lose the network, or if you are say unable to log in at any time, you can rejoin using the same number, 481109. So once you log in, your name will come on the screen. So all of you or all of us are on the same page once you log in. So I can see Jamnas, Postodons, MS, Era, Chand, Tanu. So even the online people can join, and they can interact with the session here, answer questions, send questions, give their opinions, everything on the mobile. So if you have any issues, you can contact me or raise hand. KAHOOT space IT, put the number, it will ask for a pin, and put the number 481109. Next it will ask for your name. Once you put your name, we are ready to go. Right? Everyone is on page? Yeah, so we have roughly about 61 people here who are joining online, offline, and we'll have several more who are joining online too. So once we are on the same page, we will start, and the advantage is whatever I am putting on the screen on the laptop here will be seen on your mobile phones. So you can answer questions, you can give your opinions, because many people hesitate to stand and ask questions or share your opinions. So this is easy. So you just put the button, and I will tell you how to do that also. Yes? So let us wait for 1 or 2 minutes so that all online people join. KAHOOT space IT, and you need not download anything, just put that number which is seen on the screen, 481109, 481109, put your name, and we are all on the same page. Yeah. Dental department and my department, which is mental department, are quite closely connected. Not just alphabetically, because alphabetically we are only one digit or one alphabet different. So that's why we are close alphabetically. But then even anatomically we are close. So you see the lower part, we see the upper part. And my dentistry connection is quite close. My wife is a dentist, my father-in-law is a dentist, my sister-in-law is a dentist, and several of my cousins and their wives are also dentists. And I'm only the one person who is from the mental department in between all dentists. So the connection and the understanding of dental things are quite nice. And today we will highlight one important topic which is common to both of us, is something which is nicotine and the effects, the dependence potential, the psychological issues, treatment issues, and how to motivate, how to identify, we will cover jointly. Our speaker, previous speaker, who actually performed like Surya Kumar Yadav, he is Vijay Kumar, but then he performed like Surya Kumar. And I am like Anil Kumble, who is way down the batting order. But then so the idea is to match Vijay Kumar, and we will see that we cover the 95% of the things what is not covered in his talk. He said about 100 people are there, 4 will probably have suspicion of cancer, 1 probably will be detecting cancer. So he covered the 4% plus 1% which is the cancer part. I will cover the rest 95% who don't have cancer, who don't have a suspicion of cancer, but then who have a real problem. And who are the majority of the people whom we see on a day-to-day basis, who they have not reached the stage of suspicion of cancer, but then who require actually help so that they don't reach that stage. And how to do it, we will see now. So all are ready? Yes. So we will start now. Hopefully everyone should be able to see the same screen what I am seeing here. Overcoming nicotine addiction. Yes? All of you are able to see on your mobile phones? It will come. Yes? Yes, good to go. So as part of the no tobacco world, so our job is to see that nicotine dependence, whoever have started, are handled well, are psychologically managed well, identified and treated. Yeah. I think this is a common scene, even outside the medical college. If you just go outside the gate, almost all institutions you will have some shops selling all these things, and people sometimes go in between classes, in between breaks and so on to have a puff. So it is not something which is uncommon these days, and models and stars and movie, you see it on a daily basis. So there are 3 types of usage. So people start with occasional use, once in a while. So the next stage is abuse, where they use on a more regular basis, weekends or on particular days, a particular time of the day, say mornings, say evenings, after dinner and so on, which is more like an abuse, which is a more pattern kind of use on a more regular basis, which becomes a kind of abuse. And the last one, which is of a more serious problem which can lead to many other issues, is the dependence part. So dependence or addiction. So we will look at the whole subject at 3 levels: use, abuse and dependence. Now the question is, at what stage we should act? Where should we act? So what do you think? We should act at which stage? We should act at the use stage, abuse stage, or at a stage where they are dependent on the problem, dependent on the substance? All 3? Anyone else? Which stage we should act? First stage, second stage, third stage, or before use also, correct? So we actually do intervention before the use stage itself, before the use, so that they don't start at all. Because someone who is using, there is always a chance that he will go to the abuse stage, and someone who is abusing, there is always a likelihood chance that he will go to the next stage. So it's very important that we don't allow them to use at all, and that is the best one. Now, how to identify people who actually have the severe problem? So we have issues if people have the more serious issue of dependence. So where they are unable to manage themselves, there is a socio-occupational, economic, financial angle to their addictions. It could be health issue, it could be a psychological issue, it could be multiple issues causing because of the substance. Now, why people get addicted to, say, cigarettes or smoking or nicotine? Why don't people get addicted to dosa and idlis? Do people get addicted to dosa and idli? You eat it daily, but you don't get addicted. You don't crave for idli. But then people crave for pan masala. But why? Have you thought of that? Why only cigarettes? Why you should get hooked onto that thing? So, the idea is not just in the substance. Many people say it is a dependence producing substance. Yes, so there is a potential of substance causing dependence because it increases a particular chemical in the brain, people get addicted to it and so on. But then there is a factor related to the person also. Person's nature, how person copes, the person's craving, person's character, a genetic responsibility, the family history with which he has come, the environment in which he is. So it is both ways. It's some problem related to the person, something which is modifiable, something which is non-modifiable, and also the substance what he is using. There are various substances of abuse, and each substance of abuse has various potential for dependence. So cigarette has a particular potential, alcohol has a particular potential, and you have various other substances which have even higher or lower order potentials. So it works both ways: person, environment, substance, and whole other factors which lead ultimately the person getting into dependence. I don't want to bore you with a lot of, say, neurobiology, which is one of the little boring subjects. So, but then 2-3 points you can remember. So whenever you use a substance, say for example nicotine, it enters the brain at various forms, a chewable form, a inhalation form, and say eating. So it can be from any form of the substance. It stimulates the particular receptors, and one area which it is very important is the ventral tegmental area and the nucleus accumbens. These are the seats for actually dependence potential. So it stimulates these areas and releases a pleasure chemical called as dopamine. It releases dopamine, and this rush of dopamine is what people crave for. So I smoke, I get a rush of dopamine, I am happy because of that. So each thing you do which makes you happy has a small potential to create this kind of pleasure chemical, but then it varies from substance to substance. So people get hooked on to the rush of this chemical. So say I smoke, I get a rush of dopamine which I am happy or I am looking forward to, rather than sitting and say watching TV or spending time with family, which also releases dopamine but of a little lesser level. People are getting used to the rush of dopamine, and people look forward to this rush of dopamine and want a push of dopamine to keep them happy. And once it weighs down, after some time again they want a second smoke so that again the push comes. So that is where people get dependent on the substance. So yeah, I think the net is a little slow. Now how to identify someone is having dependence? So use, you can easily say, oh, someone is using. Abuse, people use it on a more regular basis, which is probably a little easy to identify. But dependence, there is a specific criteria. How to say someone is dependent on a substance? So there are few criteria to say someone is dependent, and a simple one is ICD criteria, which probably is easy to understand and diagnose. So there are few points which people need to understand what it is, the terminologies, so that you pick the person who actually requires a definite help. And few points in this is, one is tolerance. So tolerance is the gradual increase in the dose of the substance or the frequency of the substance over a period of time. So it initially starts with 1 cigarette, 2 cigarettes, 4 cigarettes, say half packet, 1 packet, 2 packet, and that increase is tolerance. So people start with 30 ml, 60 ml, half quarter, 1 quarter, and 1 bottle is tolerance. So gradual increase in the dosage over a period of time for the same effect is called as tolerance. So that is one criteria. So what quantity he was using earlier, over a period of time it increased, is tolerance. Second one is withdrawal symptoms. So someone is addicted or using it on a regular basis, you stop one day, he is not able to tolerate the symptoms. So he develops physical symptoms, he gets psychological symptoms. So cigarette, people say I am unable to concentrate, he gets irritable, he is getting angry, so he is unable to have a proper mood, there could be mood changes. So all these could be withdrawal symptoms. So you stop a substance taking on a regular basis, people develop withdrawal symptoms. Next one is the strong desire to take the drug. So that is called craving. So intense desire. So moment I see a shop, I get the intense urge to take the substance. That is also a sign of dependence. Difficulty to control. So person thinks, oh, today he won't smoke. So, but then he is unable to control the urge. So he'll think, okay, today I will take only 2 cigarettes, though he was taking 1 packet, but then by evening he is already finished about 2 packets. So he is unable to control himself. So that is the 4th point. And the 5th one is called salience, where he keeps substance use over all other pleasures in life. So he is skipping social functions, he is skipping visiting religious places, just because he is unable to use it there. So he prefers substance over all other pleasures. He doesn't want family, he doesn't want to play with children, because he prefers, I can be with friends and smoke. So that is called as salience. And the last one is persisting to use in spite of developing physical or psychological harm. So there are 6 criteria. So there are people I know who are in the pulmonary ward, COPD ward, coughing and having chest pain and say angina and so on, still they go to the toilet and smoke. So they know they have a problem, they know it is related to the substance use, but then still continue to use. So out of these 6, tolerance, withdrawal symptoms, craving, inability to control, salience, and persisting to use in spite of developing harm. There are 6 criteria. Out of these 6, people have any 3 for a period of 1 year, that means person is dependent on substance. So he is having any 3 for a period of 1 year, it means he is addicted to the substance. So once he is dependent, our duty is to treat. There is no other choice. So the rest of the things you can still say give various options of cutting on his own and so on, but then once it reaches a condition of say dependence, it has to be treated. And people start developing physical symptoms and psychological symptoms at that level. And one easy questionnaire is there to rate the usage or how severe is the usage of nicotine, and it's called Fagerstrom test scale. So a simple test, it is having only 6 questions, it hardly takes about 2 minutes, and it gives points out of 10, and if someone scores more than 7, it is severe dependence. So it asks simple questions like how soon after you awaken you smoke the first cigarette. Do you find it difficult to refrain from smoking in places where it is forbidden? How many cigarettes per day do you smoke? Which cigarette would you like to hate to give up the most? And some simple things like this, and it hardly takes about 2 minutes. So it gives a score of how severe is the nicotine dependence. And do you know which is the most difficult cigarette to leave? Any idea? So people come down to 2 packet, 1 packet, half packet, 4 to 2, 1. But the leaving the 1 is the most difficult one. You know which one? Early morning one with the toilet or before the toilet. That's the most difficult one to leave for people who are using it on a more regular basis. So people sometimes say, I have given up doctor, most of the things I have given, but 1 or 2 I still do. And that 1 or 2 is the early morning one. So they get up in the morning, they feel like having a smoke. So this is one scale which gives the severity, and it helps you whether you are on the right direction. So you start treatment, you know after some time, you do it again and see whether it has come down. So he may be smoking, but then to a much lesser level. So it gives an idea of whether the treatment you are doing is effective. Yeah. So I'll give you a case example. There is no point just telling a lot of theories. One simple case example how things can present. So this was actually a lady who I was seeing in Yenepoya Specialty Hospital. So one evening I get a call from the cardiologist, the heart doctor. So the lady was admitted in the ICU in Yenepoya Specialty in Mangalore. She was from rural Kasaragod, about a 60-year-old lady. So she had chest pain. She underwent angiography and angioplasty, that is the heart operation, the stent one. So she finished angioplasty, she was shifted to the ICU. And once she is in the ICU after the procedure, They have to monitor, and she was with the tubes and all these things. But then she was very insisting to the doctor that she should be shifted to the ward. She was telling that I have to go to the ward. Don't keep me here, so I cannot be in the ICU. But then doctor said, you just finished your operation, you cannot be shifted like that. You need monitoring, we need the monitors to check your levels and so on. Then she insisted, no, she used to shout, and she used to get angry with the nursing staff. She started pulling the say tubes and so on, and the sister got worried. And the sister told the doctor, and the doctor said somehow that you need to be here for 1 or 2 days for observing and so on. She was not willing. She started abusing the nurse, she started shouting at the doctor and so on. Then the family was really surprised. What happened? She was fine, and suddenly what happened to this lady? They tried to convince, she was not listening. Finally, the cardiologist said, let us call the psychiatrist, because somehow she has become very uncooperative after operation. They thought the operation trauma and all would have really upset her. Then I saw her late in the night, and she said, I have to go to the room. You just send me to the room. I can't be here. I said, what is the problem? So family said everything else was fine, and she had a good operation and all. You know what was the problem? Any idea? She was a 60-year-old lady, and finally she said, doctor, I will catch your leg. Somehow you send me to the ward. I said, why you have to catch my leg and all? We are telling in your good interest. So what is the problem? You tell me. If you tell me the truth, then I will try to understand and help you. Because the way she spoke made sense. She was not confused or disoriented. Then somehow send me to the room. So I said, see, there is a procedure, a protocol and all those things. No, she said, the problem is, I have not told the doctor who operated me, I smoke. I smoke BDs, and I smoked about 2 packets of BDs. My husband was smoking. He died about 2 years back. He actually introduced me to smoking. And I have been smoking for last about 20 years. Now I smoke daily about 2 packets. And my son actually gives, because without that I cannot do. I cannot manage. So I have been smoking. Now 2 days I have not had the smoke. I cannot tolerate and be here. I am going mad. Somehow you send me here, I will have 1 or 2 smoke, and then if you want, I will come back. I said, I understand your problem, but then I cannot allow her to smoke even in the ward. So the point I want to make is, the doctors also did not even ask her, do you smoke? Why? Any idea? Presumption, correct. So it was presumption that a 60-year-old lady from a rural background, how can we ask her, do you smoke? And I checked the record, it is no entry of smoking also, but then she underwent a heart operation. So we presume that a lady, elderly lady and all, oh, she won't smoke BDs. So the presumption was wrong. Then I had to tell the cardiologist that this is the problem and all. Oh, he said, oh, she was smoking, I did not know. So then finally we had to start her on nicotine replacement therapies, and said a smoking equivalent will be provided in the ICU and will manage you well so that you don't have issues. And somehow we tried to help her and manage her with some sedatives for some time. And she was managed well for the next 2 days, and then shifted to the room. So the idea, the point I want to make is, so sometimes the smoking habits come from unexpected corners. One. The other thing is, sometimes husbands or the men are used to smoking and drinking. Who will object? Who objects if a person is smoking and drinking at home? Is the wife or the person next to you who objects. So one of the idea, the trick they use is, you make the person also dependent. So you give one alcohol to her and 1 or 2 cigarettes, slowly on a daily basis, she will also get addicted, then she will not object. The person who is objecting is also part of your team. So then there is easy go. So this also does happen. Yeah. Sometimes you need not even ask. Many times for dentists it is very easy, because anyway you ask them to open the mouth. And the other one place where you can easily see is, even with the closed mouth, is the lips and the fingertips. So this gives us the story. For me, how do I identify, you know? You have any idea? Even before talking, I look at their teeth. I ask them to smile. Hello, how are you? They smile. I know I look at their teeth and say whether they are having nicotine dependence, because it will be shown in the teeth before even you ask. So it is very important that you ask about nicotine dependence. For our branch, sometimes they may not directly come for nicotine per se, because very few people actually identify and come directly, because everyone knows, even the packet shows photos and all, everyone knows it is bad. So very few people actually come unless there is a major harm. But then a lot of psychological issues are related to smoking. So it increases, it enhances, it causes a lot of issues, right from say anxiety, depression, schizophrenia, and say mood disorders. So it directly affects, sometimes it reduces, sometimes it gives good sleep, sometimes it causes say lack of sleep, it is an activating agent, it's a diverting agent, and so on. So there are multiple ways where psychiatric issues are related to smoking and nicotine. One major problem we see is people who come with the problem with the sleep issues. So they say I don't get sleep, and when they don't get sleep, what do? Someone who is smoking, they go out and smoke, and once they smoke, the chance of sleeping actually goes down, because smoking is actually an activating agent. So you activate the brain, you have 1 or 2 cigarettes and then you don't get sleep at all, because it's an activating agent. And people who are smokers smoke in the night, which actually disturbs sleep more. So smoking and nicotine causes a very disturbed sleep, unlike the usual idea where people don't get smoke, have a stroll and then come back. And if you are a smoker, the tendency to use pan masala or at the say middle of the night smoke is quite common, and that interferes with the sleep. I will tell you a small story of a person who I was seeing how a small thing, how a spark causes a big damage. All major smokes, you know, it starts with a small spark. So everything, all substance abuse starts initially with the cigarettes or the say tobacco, and that is how it slowly progresses, and then one day it becomes a major problem. So I will tell you a story of one person, a person F, who was from Mangalore. So who was quite good. In fact, he scored distinction in one of the engineering colleges. So he was a computer engineer, did very well, and he had 4 sisters, and he was the eldest, and family had a lot of hopes because he was very good in studies, he did well, and he got a campus selection, he got job in Bangalore, and family was happy to send him to Bangalore. So till then, very nice boy, and without any substance abuse, and very obedient person, moves to Bangalore and he starts working there in IT company, and IT companies generally work for 5 days. Saturday, Sunday is off, and you get a good pay. And youngster, so where do they stay in Bangalore? Anyone fresh going to Bangalore, where they stay? PGs, correct. So he rented a PG room, one posh room close to his office space. So in PG room, who else will be there? There are a lot of others who you make friends there. So he had a big gang of people who there. Saturday, Sunday is off. Initially he used to come home quite often. Slowly he started enjoying with friends weekend. They said, why are you going home every weekend? We'll enjoy in Bangalore. A lot of money also. So then they said, why you waste time just to going around? You'll have a puff. So it starts with cigarettes. So they started offering him. He started using on a regular basis, and slowly that became a habit. So it started with use, and then slowly it became abuse, and then slowly it became dependent. So he started becoming dependent on substance, nicotine. After some time they said, what is there in cigarette? We will go for a higher one. We will smoke ganja. So that gives better kick. So you can enjoy more, you will feel more pleasure. So next step is started smoking ganja. So a lot of money started going in this. His visits coming home has reduced. So he started spending more time on this. His office performance decreased. So then the salary also started reducing because his performance was poor. He was taking a lot of leaves. Then friends told, we can make more money by selling these things to others. So you sell to others, you make money. You buy for 50 rupees and you sell for 200 rupees. You make 150 rupees profit. You learn more from what you work. So he started giving ganja to all these college students nearby thing for a higher price and making a lot of money. Then he thought, why should I actually work? I make the same money in 2 hours and much more than what I am working in office. He started selling ganja in nearby places. So he made a lot of money. So he used to get 2-3 times of what he was working, and that became a big business. Then he thought, why outside these police people are always monitoring and there is a problem with these school authorities and all. So there is no safe place. Then he started calling them home. We will give you safe place to smoke also and take ganja. Called them home and started supplying and using, asking them to use it in his flat. Then who will have problem? PG. PG owner started complaining. So he said, I will not allow this. So you are doing all this business. This is not okay. Then he thought, why all this trouble with the owner? Let me buy the entire building. So he took the entire building for rent, 8-floor flat. So one each for these 3-4 people, and 3-4 empty flats, so that people can use ganja, smoke, and then go off. He used to provide space, he used to provide the item, he used to provide everything, and they pay. So he used to make lakhs. So all this happened, everything going well. So his work time was entire night, and he used to sleep during daytime. So luck was good all these years, but one fine day what happened was, his uncle was coming from Saudi Arabia. So there was some fog in Mangalore. The flight came to Bangalore because it couldn't land in Mangalore. The flight landed in Bangalore. Uncle thought, why should I go to a hotel? Let me go to my relative's house, his house, and stay there and come back by bus in the evening. And the uncle reached there and he gets a shock of his life because his flat was actually a hookah bar. So he used to run all these things in his flat, collecting money, and he entered. All these people were in a different world. So they were literally in there, and people sleeping here and there on the corridors, and relative gets a shock of his life. He was his uncle, mother's brother. So he thought he was a very nice boy and earning well and very committed person to the family. So his values, everything is totally gone haywire. And he said, nothing doing. So you stop this, immediately we are going home, I have to tell your mother. So he brings him home along with him the same night, and he lands up in Mangalore the next day morning. So by then what happens? If someone is dependent on the substance, what happens? He starts developing withdrawal. So years he was taking regularly all these substances. The moment he lands in Mangalore and early morning, he is hallucinating. He is seeing imaginary things, he is saying people are there inside the house, he is talking as if he is in the office. So he is totally confused, he is totally in delirium. So he has developed psychotic symptoms. So he is without these substances, and mother and parents get a shock of their life. So we thought you are doing a lot of projects and very busy in your life in academic work, but then the truth was something else. So ultimately he lands in the psychiatry ward. So he was about 25, 26, he lands in the psychiatry ward for treatment. He was there in the ward roughly for about 3 weeks, and his phone was with the mother. Because he was using the phone, he was ill, the phone was with the mother. And mother started crying, saying, I can't imagine, daily morning, early morning I get phone calls from his friends. I want 10 gram, I want 15 grams, where should I come, whom should I transfer money, and so on. And the phone was coming to the mother. And she said, I threw the SIM to the flame. So I threw the SIM to the gas stove and burnt it. I don't want to hear all these things. And he gets better after about 3 weeks. And finally, I said, he's fine now, he can join back to work. And you know what the mother said? I don't want the 75,000 job. I want my son happy and say healthy. So I should see him in front of my eyes. So even if it is 25,000, I am happy, but then he should be in Mangalore. So he is now currently in Mangalore, going from home only, without going for the 75,000 job. The point I want to make is, everything starts at a very small thing. It starts with a small initial cigarette or initial substance intake, but then slowly it can consume and become a major problem. Now our duty is to identify these things, and at a very early stage you offer some treatment so that it helps people. There is a Malayalam movie, I think many of you will be from Kerala. It's on the theme of smoking cessation, how to stop smoking. The entire movie is on the same theme. Can you type so that you need not answer, because sometimes people are not comfortable answering in the public, so you can actually type. So there are awareness things happening even in the media to identify that. Yeah, I think a lot of people are answering. Yeah. So what is in the red in the middle is the right one. So T1D is tea, smoke, and even in Canada they say Ugebido, no, and so on. So T1D is a Malayalam movie which is on the theme of smoking cessation and how difficult it is and how important it is to identify at a very early stage. Now when you ask them to stop smoking or stop using tobacco, they have their own advantages why they want to continue to use. So many of the youngsters, one of the reason is they stand outside the, say, hotel or standing in the bus stop, and it's a kind of style factor. I think many people believe it is a kind of style, and some people say it is to attract girls. I don't know whether it is, how much it is true, but then if you ask girls, many of them say they don't like men smoking. So, but then men think it is to attract girls. So it improves masculine. So you have Shah Rukh Khan or say Upendra or Mammootty smoking, so it improves a kind of, say, modern image to be in company of people who are doing it. It improves concentration, so it stimulates your brain, it's a time pass, people smoke to increase concentration, improve performance and so on. So they give a whole lot of reasons why they actually do these things, but then the truth is actually the opposite. So it causes a lot of health issue, the cost factor, at the cost of family, it causes dependence, it spoils your health, and you may impress one or two people, but then you may annoy much more. So initial thing is to start with asking. So doesn't mind whether you are intervening, you are doing anything, you just ask, do you smoke? So that one question actually can stimulate a lot of people. So it may not matter once, but then many people ask at various points of time, and at each visit it definitely makes a difference. So it starts with just asking. The 5 A's is what is the approach to quit smoking. So ask about tobacco use, be it smoking, smokeless tobacco and so on. Next one is advising to quit. So you can send some messages or tell some advice, offer some advice. So there are various forms in which you can give advice, electronic, or say orally and so on, to see that they follow your advice. Third one, assess willingness to quit. So some people will get motivated over a period of time. You keep asking about tobacco in your visits every time. So one day they say, okay, so let me see what can be done. So you can actually assess and help them to quit. So you assist them in quitting. How to do that I will tell you. So you can offer various kinds of pharmacological treatment, non-pharmacological treatment. You can offer say nicotine replacement therapy so that they can have a smooth withdrawal. And the last one is to arrange follow-up and care. So if you do all these 5 things, at least a major chunk of people you can definitely help. If not that time, over a period of time they may come back to you, or they may go back to a professional. So there are something called as stages of motivation. So people may be in the motivation cycle at various stages. It starts from what we call as pre-contemplation, where they say they have no problem. They say I have no problem. So I smoke very little. They may minimize, they may deny, or they may say I have come just because my wife brought. So they may be in a stage where they totally deny, or they are not motivated to stop. So that is one. The second is you make them think, oh, probably he needs to stop. So see, you've been smoking for last 15-20 years. If you don't smoke now, stop now, so when are you planning to stop? So such things actually make them think, oh, if I don't stop now, after some time it will be still more difficult. So when will I stop? So you bring him into a stage where they start thinking something needs to be done. And then once he agrees, you prepare him, offer the menu or what can be offered, or how can we help you to say come out of the substance. You prepare him mentally, psychologically to quit, provide a quit date and so on. And the fourth one is actually start some treatment, the action, and then maintain so that he doesn't go back. So the stages are pre-contemplation, where they totally don't agree, to a stage where they think, oh, probably something needs to be done. preparation, action and maintenance, and then finally if they go back, again bring them back to the stage where you start all the process all over again. Sometimes people do relapse, people go back, but then that is natural. You assist them to come back and take treatment. There are types of how you do this motivational interviewing. So there are various mnemonics. There is something called as frames criteria. There is something called as DARES criteria. Develop discrepancy. You develop a doubt in their mind that I am smoking too much or I am using this substance too much. So something needs to be done. You don't argue with them. Don't get into an argument. You offer help and say where you see your path, where it is going and so on. You roll with resistance. They may initially resist change or they don't want to change at the initial stage. Slowly offer them help, self-efficacy and all these things with empathy. So you should understand that they have been say dependent on the substance and it's not easy to come out. So you offer all these things with a empathetic approach. So the mnemonic is DARES, what we usually call. So D, A, R, E and S. So empathy all through the whole process. So there are various other models. There is something called as frames model where you say provide feedback, offer a menu, avoid argumentation, provide a menu of how to say stop and what are the things what you can provide, and empathy and support. So usually what happens is various types of craving, a desire. So we need to understand always there are some reasons why someone desires something. So for example, someone sees this, they get an urge to have a French fry. But then what was the desire? How did that French fry come to your mind? You think, see this, you get an idea. Okay, so probably I should have it today evening. That is because of the cue. You saw a photo or something that gives you an urge. So there can be a cue of a cigarette packet or a matchbox which can give a cue to that craving. It could be time. So early morning, evening, seeing the friends, a particular time of the day. Another type of craving is dysphoria. You are upset about something, you have some exams, you had a fight, so some irritated mood, then people have an urge to use the substance, or one use leading to subsequent use. So someone gives a puff or you smell the smoke, that gives a urge to smoke or get the craving. So there are various types of craving or various types of reasons why people start using the substance. Now actually if you want to stop, help someone stop, what can be given or what can be offered? Initially there are two drugs which usually helps in reducing the craving or reducing the urge to smoke. So one is the bupropion tablet, which is basically an NDRI, so that is noradrenaline dopamine reuptake inhibitor. We start with 150 mg OD and slowly after about 2 weeks you can make it 150 mg BD, given for about say 6 to 12 weeks. It helps in reducing the urge to smoke. That is one tablet which is generally offered. There is one more varenicline tablet which acts on the nicotine receptors. It's a nicotine receptor agonist. Its international name is Chantix, but in India it is called as Champix, and the their tagline is actually Champix is use Champix and be a champ. So CHAMPIX. So Champix 0.5 mg and 1 mg. So you can start with 0.5 mg and after about a week you can make it 0.5 mg BD. It helps in reducing the urge to smoke and it works much better than bupropion, but then it is little costly. The other options are nicotine replacement therapies. You offer some other forms of nicotine so that the body gets nicotine but not the cigarette or the smoke. So one option is nicotine patches. So we get patches of various strength, say 7 mg, 14 mg and 21 mg, and depending on the number of cigarettes or smoke non-smoking packets he is using, you can use a particular type of dosage of the patch. So it is stuck to the body, it slowly absorbs nicotine and the urge to smoke actually reduces. Nicotine patch is quite convenient, people don't see it from outside, you can stick it to the body and it works 24 hours. So it's quite an advantageous type of nicotine replacement. You have nicotine gums, so chewing gums, which is people get advertisement even on the TVs and all. So you get 2 mg and 4 mg chewing gums. So you can keep it in the mouth, but the only disadvantage is you keep it in the mouth for a long time, it gives a kind of say a heat kind of sensation, sometimes a burning because it has strong nicotine content, and some people find it difficulty to use it at particular places, you have to spit it. So there are a few disadvantages of smoke nicotine gums, but then it is quite cheap and widely available. You have nicotine lozenges, something like chocolates, where you keep it in the mouth, you can suck the liquid and you need not spit it. So entire thing you can swallow. This also comes in 2 mg, 4 mg. It's a little modified version of the gums, where lozenges is more softer and more palatable and easy to swallow. But then all these things, people find the problem is it provides nicotine very slowly. I eat the gum, I chew the gum, or I eat the chocolates, patches, it releases nicotine very slowly. But smoking, people get the nicotine rush very fast. So I smoke, I get nicotine. So that fastness people miss, and for that people started developing nicotine sprays. You just take 2-3 sprays to the nose. So you just press it, the nicotine spray goes to the nose and you inhale nicotine and it acts fast. So nicotine sprays is costlier but acts faster. Then you have something called as e-cigarettes. So it is banned in few states but available. So e-cigarettes is like a pen. So you charge it using your, like how you charge your mobile phones. At the end you get a light, so you can keep it in the mouth, you can inhale the say vapor, so it gives a kind of nicotine which can be a refill, and it gives a light on top. So it is almost similar to a cigarette but then without smoke. So e-cigarettes is something which helps in say removing the habit of smoking. But the problem is many people get addicted to the e-cigarettes also. So it gets, you can have refills of nicotine of various flavors depending on the choice of flavor you want. So advantage of e-cigarettes is tobacco is not there, no tar, no smoke, no odor, it saves a lot of money, it satisfies the craving, it can be used anytime, anywhere, and the strength of nicotine you want to put also can be controlled. So people want any help in assisting or say helping people with the nicotine addiction, so we can help. At Yenepoya we run a helpline which can be used at any time, anywhere for any of the psychological problem, and the number is 910-89-19025. And many people ask, is there a best medicine to stay out of all these things? And the best medicine to stay out of all the problems including substance abuse is laughter. So you laugh 3 times a day, so that is the best medicine to stay away from stress, substance abuse and mental illness. So but then laugh only with a reason. If you laugh without reason, then the reason may be something else. So laughter is the best medicine to help people stay away from substance abuse, and that brings us to the end of the presentation. So before we conclude, there are people who want to take some questions. You can type the answer so that we know you have learned something. When is the World No Tobacco Day? Feb 17th, Feb 28th, March 31st, May 31st. Some learning at the end of the day. World No Tobacco Day is on May 31st. So many of you got it right. So I think Sharmi, Karun, Rekha are answering well. So next question. Can you identify this substance? Can you identify what is shown in the picture? You can type your answer there, what it is. It is put in a vessel kind of thing and some powder is there. So many people, because sometimes many things people use but then we don't know that they are using. And this is one such substance, and sometimes people carry it in their saris or say mundu and all and keep, and they use it even in front of us and people we don't know. And the answer is Yeah, so a lot of people have answered correct. The answer is snuff powder. So it's a tobacco powder which many people inhale and put it directly to the nostrils. It is very strong, it acts very fast. So that is snuff powder. Yeah, I think Sharmi is answering well. Yeah. Next one, gradual increase in the dosage of substance to get the same desired effect is called as withdrawal effect, salience, tolerance, craving. So people use the substance and increase the dose over a period of time is called as what? Withdrawal, salience, tolerance, craving. Yeah, the answer is tolerance. So I had covered it during the presentation. So gradual increase in dosage of the substance is called as tolerance. Stopping causes withdrawal, and the salience is giving substance more importance than any other pleasures, and craving is intense desire. So Sharmi has come down. Ira has stopped. Who is Ira? Ira is here or online? Oh, he is there. Nice. Okay. Next, puzzle, arrange in ascending order of the cycle of motivation items. So you can move the say bars and arrange in ascending order. So what is given is maintenance, action, contemplation and preparation. So cycle of motivation, how they move in the cycle of motivation. The system calculates the speed with which you answer also. So many people answer correctly. Who answers first gets higher points. So it considers both the right answer and the speed. So right order is contemplation, preparation, action and maintenance. And in case there was a pre-contemplation, that will come first. And we will see who has answered well. Oh, Rekha is on the lead. Ira, Saj, Kat and Shalu. So the last one, I think one more. Yeah. The best modality of treatment for nicotine dependence is nicotine replacement, bupropion plus CBT, varenicline plus nicotine replacement. And answer D, varenicline, nicotine replacement plus CBT. So if you want to help someone, which is the best option, if you have all the options. And the right answer is the last one, varenicline, which is anti-craving agent, nicotine replacement therapies plus cognitive behavior therapy or some kind of counseling. So that brings us to the end of the whole presentation. And best answer was Dr. Rekha. So congrats. And who is Saj? SAJ? Yeah, congratulations, he is second. Someone with the name Devil? Good. And we have Kat, yes, and Sharmi Karun. Yeah, congratulations. So this shows there is some effect of the whole exercise. And if you have any questions, you can type the questions and I can answer. You need not stand and ask, you can type it here and it will be shown on the screen.
Any queries from the audience?
If you want the mic, we can provide the mic, or if you want to ask on the mobile, you can type the questions, we can answer.
Sir, often when we go to schools, students often say that among peer groups, when they are offered for the first time, it becomes difficult to say no. So can you tell us what are the possible ways in which young children who are offered it for the first time can say no?
Very good point. I should appreciate that question. How to say no? Actually, I feel the art of telling no should start from schooling, from the school age, because majority of our children, our system is tuned to say yes. Our children are brought up in such a say world that they are told to say yes. You want to participate? Yes. You want to do this? Yes. You want to participate in running race? Yes. They are tuned to say yes more than say no. So the art of saying no should be learned by students. So it is okay to say no, and people can agree to disagree. So I may be friends with someone. So if I say no, it doesn't mean I am against the friendship kind of thing. It is just for that kind of point. So I think that culture needs to be developed in our kind of society. Western society, they are more tuned to saying no. They can refuse, they can say no even to elders and so on. But our kind of system, it is like obliging kind of thing. We are more obliging kind of society where the tendency to say yes is much higher. But then I feel it should start from the schooling days where children are taught to say no to few things, but that doesn't mean it affects our other kind of relationship. So someone offers cigarette, I can say no, but then our friendship should still continue. So that is an art which we need to tell from the growing phase, but then it is very important that people learn to say no and also continue, say, the other kind of relationship. It's an art to be developed. Yeah, we have few questions, if possible I will answer. Can threatening actually work, or it actually worsens the condition? Yeah, good question. So threatening is like a policing. So a simple example I would give, wearing helmets. So police people stand some people, so what people do is, for the threat of police they wear, and once they cross that place they put it back in the hand or in the handle. So it works unless there is a motivation, it doesn't work all the time. So policing works to some extent at some point of time, but then what comes from within is the best. So it is like mother is there, the child opens the book. Once the mother goes, the book is closed and you are on the mobile. So if mother is around, it works, but then we want the child to learn from within. So I think it may work to some extent at some point of time, but then what comes from within is the best. What if they don't want to quit? Yes. So there is no harm in trying. So it is like keep on saying whenever, say, if you want to come or you change your mind, you come back. So they may not agree all the time. I say once, I say we can offer help. He may say no, I need not feel bad. So at least I have conveyed the message. Sometime later he may change his mind. So you keep trying, you keep asking. So at some point of time he may change the mind and come back to you. So you keep trying is the answer. How do we motivate someone feels defeated after failing to quit before? Very good question. So 75% of the people actually fail. So they come, they take treatment, they fail. So but then we shouldn't lose heart, he also shouldn't lose heart. We can work together. So in the cycle of motivation there is a kind of relapse. So they relapse, they can again come back to the cycle and continue the treatment again. We should be okay with offering treatment again, continuing. So nothing to feel defeated. Defeat is a part of the whole process. Is vape banned in India? It is not banned, but then it is something which is say regulated and not forbidden to use among minors, but then it is available. How do we do if someone, or what do we do if someone doesn't want to acknowledge the use? Yeah, same thing. If you want a proof, we can show the proof. Any idea how to show proof? So drug screens we can do, all urine drug screen we can do to test whether someone is taking the substance. There are many people who tell no. So I can lie, but the test will not lie. So you can say we can provide the proof. So we can do carbon monoxide testings, we can do cotinine level testings to show that there is nicotine in your body. So we can test the breath. So we can have breath analyzers, breath cotinine levels, blood cotinine levels. So it is a proof to show that you are doing this. So someone who is asking proof, you can actually provide proof, but then I don't think it should be done on a routine basis. So if someone is actually wanting some kind of proof, that can be provided. What can we do about fourth hand smoking? Yeah, so this third hand, fourth hand and all, there are people who do, I mean, other than your say self, other than people who are smoking other than self. So it could be family members, it could be outsiders and all. For this we need a kind of say social awareness, and people stop smoking at various levels. Outside too, and some kind of regulation actually helps. So it may not be at an individual level, so it is important that the whole society understands this. To stop a addiction, it takes 30 days. After that, is it lifelong effort? It is actually a lifelong effort. All these addictions, people can anytime go back to the previous thing, because sometimes stress comes, some issue comes, life changes, life event comes and so on. But then it's a process where you help them throughout the life cycle. But what study says is, if someone has remained abstinent for 1 year, the chance of him remaining abstinent longer is much high. So your job is to see that hand-holding at least for 1 year. So before 1 year, the chance of relapse is very high. So if he stopped for 1 year, then the chance of him stopping longer is very good. So whenever I ask questions, I ask, if they tell that I have stopped, I ask how long. So if it is 1 month, 2 months, 3 months, 6 months, everything means the same. So what is different is only if I stop more than 1 year. Last question, can occasional use cause harm? If you ask, you are expecting yes or no, probably answer is not harm at that level, but then it can always lead to abuse. So the chance of him using or using the modality whenever he is under stress or whenever the occasion or the situation changes is very high, so that the best thing is you stay away from use. Okay, I think I have covered everything. Sir wants? Last one?
So many questions for you.
Yeah, I think...
you ask them to put their name, I want to know whether
no, the idea of putting it is easy is because many people hesitate to, I believe many people hesitate to ask in front of a crowd. This is a very easy way. How long nicotine traces remain in the body after quitting smoking? Generally about 3 days. Generally about 3 days is very high. It remains to about a week to 10 days, but then the levels go down and it is say ambiguity, so you cannot say with proof, but generally within 3 days it is confirmatory.
You suggested 2 drugs.
Yes.
Can you tell us, are there any side effects of it and how long they need to take it?
Yeah. So the 2 drugs for craving is, one is bupropion, which is a little older one that's been in the market for about 2 decades. So it comes in 150 mg and 300 mg. So you start with the OD 150 mg and then you make it BD. So bupropion, generally side effects are generally mild ones, that some kind of sedation or gastric irritation and so on. But only one issue where you have to be a little careful, it can induce seizures at a little higher dose. So someone who is already having seizure problem, it's better to avoid bupropion. So by and large is fairly well tolerable drug, bupropion. Varenicline is a much better one, which is a more recent one. It comes in 0.5 and 1 mg. It comes with the trade name Champix. So side effects are much less, mild side effects which can be managed even by a dentist. So only issue is varenicline is little costlier. It comes to about 3,000 to 4,000 rupees per month, the whole treatment thing. But then many times I ask the company people, why don't you reduce? And they say they spend more on cigarettes. Cigarette they give, why should we reduce? So that is the answer. But then varenicline is much better. If someone can afford, varenicline is a better choice. Side effects are quite manageable. Except for seizures with bupropion, other things are quite mild ones.
How long they need to take?
About 6 to 12 weeks. Ideally 2 to 3 months, and then you slowly taper and stop. And in between you start nicotine replacement therapies. Nicotine replacement therapies also you start, and also some kind of psychological intervention. Prashant sir wanted to ask him.
regarding that question of vape is banned in India. I think it is banned. In 2019, see, possession of a vape in your hand, police can arrest you. It has happened. Possession of a vape in your hand. So whoever is thinking vaping is safe, because in 2019 in the parliament it was banned. Now if you see a lot of manual, all these raids are happening only the shops where they are keeping your vape. Actually, I think if I'm wrong, just as such, electronic cigarette, because the act I feel it was something like
Yes.
electronic cigarettes. Vaping is sort of an electronic cigarette. Possession itself is wrong. Police can arrest you. I
Electronic cigarettes are banned in Karnataka. It depends on state to state. So Karnataka it is banned. But smoking is allowed, but vape is not allowed. It depends on place to place.
So it's Prohibition Electronic Cigarettes Act.
No, that is Google.
Yes.
I'm saying because this act was because there was a big debate in the parliament, if I remember, in 2019, the COVID time. So that was because in US, every children are getting, because it is easier to carry.
Easier to carry.
Easier to this thing hide, no smell. Because of this, at the age of 12 or 10, they are getting addicted.
Yeah, it depends situation to situation, sometimes places also, and earlier we used to have announcements in the flights and all that vaping and smoking is banned and all. So there are people who carry it also. So I am not sure about exact location, but it varies from place to place and state to state. So regulations change, but then see, ultimately the thing is availability. Even if it is banned or not banned, it is available everywhere. It is available everywhere, so people get it very easily. So self-control is the best control. So availability, even many things are banned in Gulf countries, but then you get everything there also. So it is how you regulate yourself. The ultimate thing is whether police is there or not there, you should be wearing helmet. So if you have that kind of orientation, you need not bother about what the regulation is. You do the right thing. I think with that I will end the presentation and thank the organizers for giving me an opportunity to share my views. Thank you.
Thank you, sir, for that insightful lecture. Now I request Dr. Prashant Shenoi along with Dr. Veena Jagdish and Dr. Rekha Shenoi to hand over the memento to our resource person, Dr. Anil Kakunje, as a token of appreciation. As we conclude our program, I would like to invite Dr. Anu Babu, Lecturer, Department of Oral Medicine and Radiology, to present the vote of thanks.
Good afternoon, everyone. Distinguished guests, esteemed colleagues, faculty members, postgraduate students, and interns. It's my privilege to extend the vote of thanks on behalf of Tobacco Cessation Center, Yenepoya Dental College. We begin by expressing a profound gratitude to the visionary leadership of Yenepoya Deemed to be University, Honorable Chancellor Dr. Yenepoya Abdullah Kunyi, Honorable Pro-Chancellor Mr. Farad Yenepoya, and Dr. M. Vijay Kumar. A special and heartfelt appreciation to Honorable Pro-Chancellor and Director CEO Zuleika Yenepoya Institute of Oncology, Dr. M. Vijay Kumar, sir, for graciously agreeing to serve as the chief guest and the resource person for the CDE program. We also extend our sincere thanks to Honorable Vice Chancellor, Dr. K.S. Gangadhara Somyaji, sir, Honorable Pro-Vice Chancellor, Dr. B.H. Sripati Rao, sir, Registrar, Dr. Ashwini Datta, sir, for their unwavering support and guidance. We are honored to have President, Indian Academy of Oral Medicine and Radiology, Dr. Prashant Shenoi, as guest of honor, and thank you for your inspiring presence and invaluable contributions to the Academy as well as to the event. Our appreciation is equally due to Principal Yenepoya Dental College, Dr. Lakshmikant Chhatra, whose constant support and encouragement has been instrumental in day-to-day operations of Tobacco Cessation Center and the seamless conduct of this program. We are also thankful to Dr. Shamis Bhatt, Dean, Yenepoya Dental College, Vice Principal Dr. Hassan Sarfaraz, and Secretary, Islamic Academy of Education, Dr. Akhtar Hussain. Your guidance and leadership continue to inspire excellence in all our endeavors. We express our sincere gratitude to Dr. Anil Kakunje, sir, Professor, Department of Psychiatry, for kindly agreeing to serve as the second resource person. We are deeply thankful to Indian Academy of Oral Medicine and Radiology, as well as all the registered members and the attendees whose presence has enriched this gathering. A special note of gratitude to all the heads of the department, faculty members, postgraduate students and interns from neighboring colleges for their active participation in this gathering. We are grateful to acknowledge heads of the Department of Collaborating Departments for this event, Dr. Veena KM, Department of Oral Medicine and Radiology, Dr. Rekha Shenoi, Department of Public Health Dentistry, Dr. Ravi Chandra Karkala, Department of Psychiatry. Our thanks also extend to all the heads of the department, faculty members and postgraduate students from various departments of Yenepoya Dental College. Finally, we commend the team responsible for food and refreshments, venue setup, logistics support, ensuring a flawless conduct of this program. We would also like to thank Mr. Manoj, a representative from Femura, for supporting this event. A special mention to all the members of Tobacco Cessation Center, postgraduates from both Department of Oral Medicine and Radiology, as well as Public Health Dentistry for their tireless efforts. To all the postgraduates who are attending this program, interns, and the other faculty members, we hope this session has been profoundly knowledgeable and equipping, fostering a lasting impact on your practice towards oral cancer Mukta Bharath. Thank you.
Thank you, Dr. Anu. We sincerely hoped you found the program enriching and insightful. Thank you all for being here today. I request everyone to rise for the national anthem.
Janagana Mana Dinayaka Jaya He Bharat Bhagya Vidata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchchala Jaladitaranga Tava Shubha Name Jage Tava Shubha Ashisha Mage Gai Tava Jaya Gata Janagana Mangala Dayaka Jaya He Bharat Bhagya Vidata Jaya He Jaya He Jaya He Jaya 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 He.
I request all the delegates to join for a group photograph. I kindly request all the delegates. I request all the delegates to kindly scan the QR code and fill the feedback form, and the certificates will be issued once you all fill the feedback form. I request all the members from the Department of Oral Medicine and Public Health Dentistry to come forward for the group photograph. Kindly scan the QR code.